Good morning, all guests of honor. I am Dr. Pair Pongsajarannon from Chulalongkorn University, Bangkok, Thailand. I am responsible to the MC of this event. Welcome to the United States National Eye Institute Association of Southeast Asian Nation Ophthalmology Society, Thailand Virtual Symposium on Vision Health Science. The first topics will be the opportunities for international collaborations in scientific research in ophthalmology. Without further ado, please join me to session 1, which is the opening session by the chairperson and co-chair. Dr. Michelle Brinks, Chair Vision 2020 USA KCI Institute, and co-chair is Dr. Manat Potapon, Deputy Director General of the Department of Medical Services, Thailand. Please welcome.
Thank you, Dr. Pair, and good day to all, and Savare Krap. Thank you to Dr. Manas Potapon for joining us as a co-chair for this first session. And I'd like to also thank all our attendees and our researchers, educators, clinicians, scientists, and government leaders who have joined together to welcome a new era in ASEAN country, Thai, and U.S. international collaborations in vision and eye health science. As many of you have shared your thoughts with us over recent years, what we've come to learn is that we've reached a key moment to advance global vision health science. This opportunity comes to us as there is growing research expertise across the world, new institutional partnerships developing, and rapid advances in our ability to gather and exchange data, all of which lead to the chance to share in the work and rewards of scientific discovery across ASEAN countries and the United States. The United States and countries in Southeast Asia have a long history of scientific collaboration. However, there's no standing forum to discuss challenges in vision health science and to set a bilateral scientific and public health research agenda to address the burden of eye disease between the U.S. and countries in the region. We have come together here to explore this challenge with support from the U.S. Embassy in Thailand, the Department of Medical Services of the Ministry of Public Health of Thailand, the National Eye Institute at the National Institute of Health in the United States, and the Association of Southeast Asian Nations Ophthalmology Society, as well as experts from many renowned institutions. Our discussions will explore key areas of mutual interest and describe grant mechanisms in the United States that may be available to researchers in the ASEAN region. We will also provide models of international scientific collaboration, including training opportunities. Following this symposium, we look forward to education on research collaborations that will grow not only across ours, but future generations and advance vision health science discovery for all of our countries. Thank you again for joining us today. And now I'd like to welcome remarks from Mr. Michael Heath of the U.S. Embassy in Bangkok. Mr. Heath is a Charge d'Affaires at the U.S. Embassy in Bangkok, Thailand. He was previously acting Deputy Chief of Mission at the U.S. Embassy in Canberra, Australia, and Consul General in Chiang Mai from 2013 to 2016. He previously held overseas positions in Beijing, China, and Dar es Salaam, Tanzania, and began his Foreign Service career in Guyana. At the State Department in Washington, D.C., he served as Senior Country Officer for Indonesia and as Trade and Investment Officer in the Bureau of African Affairs. Now we'd like to welcome recorded remarks from Mr. Michael Heath.
Sawadee Krap. Good morning. Deputy Prime Minister and Minister of Public Health, Anutin Chanvinirkun, Deputy Director of Medical Services, Dr. Manut Potapon, distinguished guests, ladies and gentlemen,
Mr. Heath's,
I'm very pleased to welcome you to this symposium on
mute.
vision health science. This event, for the first time, brings together eminent researchers from the United States and Southeast Asia to discuss priorities, opportunities for international engagement, and scientific and public health research on ophthalmology. While cooperation on eye health is new, U.S.-Thai cooperation on health is well established. For over 60 years, health cooperation has been a cornerstone of the U.S.-Thai relationship. Several U.S. government agencies, including the U.S. Centers for Disease Control and Prevention, the National Institutes of Health, Armed Forces Medical Research Institute, and the U.S. Agency for International Development, have collaborated with their Thai counterparts and across Southeast Asia to address important health issues. American and Thai healthcare workers and scientists have collaborated on groundbreaking research to improve health, including combating HIV/AIDS, malaria, dengue, Zika, and other infectious diseases. Through a long-standing partnership with the Royal Thai government, the U.S. government has played a crucial role in Thailand's successful response to past and present outbreaks, including severe acute respiratory syndrome, or SARS, H5N1 avian influenza, Middle East respiratory syndrome, or MERS, and currently the COVID-19 pandemic. And in fact, our CDC office in Thailand is the largest CDC presence outside of its headquarters in Atlanta. Through USAID's Child Blindness Program, the United States prevents and treats blindness, restores sight, and provides eyeglasses to children with an emphasis on quality and innovation. Since 1991, the generous support of the American people has made it possible to provide quality eye care to over 7 million children in 25 countries, including those in Southeast Asia. And now, looking toward the future, I'm certain the National Eye Institute, along with Thailand's Ministry of Public Health and partners gathered here today, will continue to advance the partnership on health between Thailand and the United States that has brought such benefit to both of our countries and across Southeast Asia. I would like to take this opportunity to thank the staff of the Ministry of Public Health, the National Eye Institute, and the Association of Southeast Asian Nations Ophthalmology Society, who made this event possible. And I would also like to thank everyone participating in today's event. I'm confident we will continue to work together to advance vision health research and to make Thailand a global hub for addressing blindness for many years to come. Thank you so much for joining us today.
Thank you, Mr. Chair and Mr. Nico Hill, for your remarks. I am now pleased to welcome His Excellency Mr. Anutin Chanvirakul, the Deputy Prime Minister and Minister of Public Health Thailand, who always support us in making healthcare available to all. He is going to take us through his pre-recording opening remarks. Now,
Mr. Michael Heath, Charge d'Affaires, United States Embassy to Thailand, distinguished participants, ladies and gentlemen. It is my pleasure to deliver an opening address at this important virtual symposium on vision health science. The COVID-19 pandemic presents an unprecedented challenge to public health and economy. It has significant impact on our people's health, especially the vulnerable populations. People with eye diseases who live in poverty in rural areas are among the affected populations. They were not able to access their routine eye care, thus increasing the risk of visual loss and blindness. Globally, at least 2.2 billion people are suffering from visual impairment and blindness. Almost 0.5% of these are people who live in Southeast Asia. Population growth and aging, along with lifestyle changes, will lead to increasing numbers of people with eye conditions, which can result in visual impairment and blindness in the coming decades. This would definitely pose a burden in healthcare and economy of countries, not only in this region, but also in the world. However, it should be emphasized that most of the causes of visual loss are preventable. So it's now time for us to work together and make sure that no one is left behind, in particular, those who are a vulnerable group of people. I am glad that the United States National Eye Institute and Department of Medical Services of Ministry of Public Health of Thailand has co-organized this very important symposium. to explore priorities and opportunities for collaborative research in vision health science between the United States and countries in Southeast Asia. This symposium will be a platform for us to mark our long-standing collaboration between the United States and ASEAN, and also a platform to strengthen the network of experts and researchers to exchange information, ideas, experience, skills, and knowledge in vision health. It will also lead us to further develop joint actions to address the burden of eye diseases and to prevent visual impairment and blindness in our ASEAN region. I trust that all participants will have constructive discussion on how we can move forward and expedite our commitment in reducing the risk of vision loss in a more effective and sustainable manner. May I end my remarks by wishing you all a good health and safe from any health threats. Thank you. ขอบคุณครับ
We really appreciate the input message to our event today. Next, I would like to invite Your Excellency Manaswi Sisodapon, Ambassador of Thailand to the United States of America, to deliver a welcome speech. Your Excellency.
Greetings. Can you hear me?
Your Excellency.
Yes.
Okay, thank you. Greetings, Dr. Brinks and Dr. Potapon, co-chairs, Dr. Chiang, National Eye Institute, Dr. Lim, ASEAN Ophthalmology Society, and dear participants. I wish to thank the National Institute of Health and the State Department for the invitation to join today's virtual symposium on vision health science. I also want to thank the National Eye Institute, as well as the Department of Medical Science, Ministry of Public Health of Thailand, for co-organizing this important and timely symposium. Allow me to offer 3 short remarks. First, as His Excellency Deputy Prime Minister Anutin Charnvirakul mentioned in his opening remarks, eye health and vision have important implications on the quality of life, livelihoods, and well-being of individuals and society. As developing countries constitute the bulk of people with visual impairment and blindness, this poses a great obstacle to the achievement of the UN Sustainable Development Goals. Action to prioritize eye health is therefore critically important. Secondly, international collaboration to share experience, to conduct research, and to build capacity, among others, will help to ensure that no one is left behind. Access to affordable, quality eye health care and treatment for the poorer segments of society, for people in remote areas and populations in lesser developed regions needs to be improved in order to address pervasive inequality. This can best be achieved through international collaboration and engagement. This is why Thailand welcomes very much the collaboration that is taking place between the United States, Thailand, and ASEAN, as manifested by the organization of today's virtual symposium. Thirdly, allow me to applaud the good work and cooperation under the auspices of the ASEAN Ophthalmology Society. This is a model of ASEAN cooperation, solidarity, and networking at its best to help shape an ASEAN community of one vision, one identity, and one community. That is a region with high quality eye care and a region with perfect vision. Thank you very much, and may I wish all participants a productive discussion and good health. Thank you.
Thank you, Ambassador. We very much appreciate those remarks. Now I'd like to introduce Dr. Michael F. Chang, our next speaker. Dr. Chang is a director of the National Eye Institute of the National Institute of Health in Bethesda, Maryland. Between 2001 and 2010, Dr. Chang was a Cohen Associate Professor of Ophthalmology and Biomedical Informatics, specializing in pediatric ophthalmology and strabismus, all at Columbia University. From 2010 until 2020, Dr. Chang worked at the Oregon Health and Science University's Casey Eye Institute, where he was the Knowles Professor of Ophthalmology and Medical Informatics and Clinical Epidemiology. Dr. Chang's research develops and applies biomedical informatics methods to clinical ophthalmology in areas such as retinopathy of prematurity, telehealth, artificial intelligence, clinical information systems, data science, and genotype-phenotype correlation. Among other scholarly activities that include over 200 publications, Dr. Chang has served on the editorial board for the Journal of Ophthalmology and also for the Asia Pacific Journal of Ophthalmology. Dr. Chang, we welcome you for the remarks and welcome aboard.
Mitch, thank you. It's great to see you. And it's evening on the East Coast right now. And I'm really excited because as I look through the list of speakers here, there are so many close friends and people that I've known for years. And so for me, this is basically like spending a night with friends. And as director of the National Eye Institute, I'd like to say that our mission is to eliminate blindness through research and through dissemination of knowledge. And blindness is really a worldwide problem that we cannot solve alone. So from that perspective, we're really excited about the prospect of global health collaborations and the opportunities where we can work together with investigators in the ASEAN region on programs that get us closer to that mission. And along those lines, we're also really excited to explore ways of expanding the National Eye Institute's international training programs in the ASEAN region as a mechanism to promote further collaborations. And so I just want to thank a few people. Number one is Mr. Antuan, the Thai Deputy Prime Minister. Number two is the ambassador, for being here. And number three is Mr. Heath for those remarks. I want to thank Dr. Samask and Dr. Manas, who are the Director General and also the Deputy Director General of the Department of Medical Services at the Thailand Ministry of Public Health. And I'd like to thank Dr. Peter Kilmarks, who's the Deputy Director of the NIH Fogarty Center, who's going to be speaking here. And lastly, just thanks to all the people who organized this program. Mitch, to you, to Dr. Paisan, and to Paul Chan, and to the MC, Dr. Pear, and obviously all the ASEAN colleagues who are speaking at the symposium. So, we are really looking forward to this, and more importantly, looking forward to everything that comes afterwards. So thank you, Mitch.
Thank you, Mike. We very much appreciate you being here and look forward to exciting discussions to come this evening. And now I'd like to turn the floor over to Dr. Manas.
Chair, without further ado, may I invite Dr. Lubin Lim, President of ASEAN Ophthalmology Society, to deliver your remarks.
Thank you. Hello, everyone. So on behalf of the 10 member nations of the ASEAN Ophthalmology Society, I would like to welcome all the speakers and attendees to this symposium on Vision Health Science, spearheaded by the U.S. National Eye Institute and the government of Thailand. The ASEAN Ophthalmology Society is indeed honored to be an active participant of this milestone event that highlights the importance of cooperation and collaboration across borders in the pursuit of scientific and public health research in ophthalmology. I congratulate the organizers for putting this symposium together despite the challenges of the times. No pandemics can prevent the sharing of knowledge. Thank you all.
Thank you, Dr. Lim. Your inspiring message is really appreciated. And thank you all for the excellent insight. We have come to the end of the first session. It is a great honor for me to be with you today. Thank you very much and wish you a successful meeting. Now over to the chair.
Thank you so much, everyone. So we will move to the next session. So the next session will be panel discussion of NIH and NEI research programs and funding opportunities. Please welcome Chair of the session, Dr. Gayan John Prakash, Director Office of International Program NEI NIH, and co-chair of this session is Dr. Peter Kumas, Director for Gadi International Center of NIH. Please welcome.
Good morning and good evening to my colleagues here in the United States and also colleagues in the ASEAN region. And I'm John Prakash. My NIH colleagues join me in welcoming all of you to the NIH session. This is a session that is going to discuss various things that we have at NIH, and we'll try to provide you a summary of some of our activities. But before we start our session, it is an honor for me to introduce my co-chair, Dr. Peter Kilmarks, who is the Deputy Director of Fogarty International Center. And let me just get to my slides. Ms. Ann, can you turn on my sharing screen button, please? Okay, Dr. Newhold, can you hold on a second? Let me just quickly run through my presentation, which will give a background to the NIH program. So can you hold for a second, since we all have privilege now? Okay, so, all right. So thank you so much. I think we have the slide privilege here. All right, so that's about me. I'll move on to my co-chair, Dr. Peter Kilmarks, who is, as I said, is the Deputy Director, and it's an honor and privilege to be working with Dr. Kilmarks, who actually has a lot of experience working in the ASEAN region, particularly Thailand. So we go to the next slide. Okay, so I'm going to just quickly talk about, the National Eye Institute, global opportunities for vision research and training. And this is a quick disclaimer here. We're moving on to the next slide, which, what you see here in the picture is an aerial view of National Institutes of Health, which is just outside Washington, D.C. Many of you have been here, but some of you who have not been, we definitely welcome you when everyone starts traveling. But I wanted to actually point out to you that National Institute of Health conducts and supports medical research to uncover new knowledge that improves the health of all Americans. And the next wording here is a sentence of talks about the human condition throughout the world. So clearly we have interest in the health of folks all around the world, and we work with people and scientists, clinicians all around the world. And National Eye Institute is one of the 27 institutes, and it's here. These are the other institutes, and I'm not going to go into detail here. The mission of National Eye Institute, just quickly to just make you familiar with that, information that, we conduct and support research training, health information dissemination, and all of the programs, everything that relates to the blinding eye diseases and health problems and requirements of the blind. We also conduct basic research, clinical research, and everything in between. And essentially advancing the knowledge of visual systems in health and disease, and to help and prevent and treat eye diseases. And therefore, as Honorable Ambassador mentioned, that improving the quality of life is just a very important mission. Just to give you an idea, this year's appropriation budget for National Eye Institute is about $835 million. So clearly a significant effort on the part of the U.S. government to really dedicate this budget, this amount to the research in blinding for blinding eye diseases. This is a quick sketch to just to give you a background of what we do and how we do science and everything all around it. So National Institute of Health, which NEI, National Eye Institute, is a part of, clearly has three broad areas: research programs, training programs, and many special programs that we do. And as many of you know, that NIH has played a key role in developing COVID-19 vaccine. So clearly, from time to time, we play a key role in the overall public health environment. And in the research programs, so we are divided between the extramural research and intramural. Essentially, extramural research that the money that is goes outside the NIH to support the research and for investigators all around the US as well as all around the globe. And for intramural, essentially we have our own laboratories across the NIH that conduct research within our own laboratories. And we have several thousand, close to 20,000+ scientists who work within the NIH campus. In the extramural research, these are, as I said, the research grants, they go out, and intramural is internal research. In terms of training, which Dr. Michael Chang, our director of National Eye Institute, he mentioned that training is a very important part of our mission. We have long-term training programs as well as short-term training programs. And I'm going to touch upon a few of these things. And clearly, we all know global blindness is a serious problem. At least about 2.2 billion people around the world have vision impairment, and of whom at least 1 billion have vision impairment that could have been prevented. So, which is a very, very, very important number and important consideration to know that a large number of this could have been prevented. And 90%, unfortunately, of the global burden of eye disease is shouldered by developing countries. And, ASEAN really has a large share of it. So comprehensive research strategy with international collaboration between the developed and developing world is very much needed. And this was highlighted by the Honorable Ambassador just a few minutes ago. And a wider collaboration of researchers is needed to advance the high quality science. And therefore we have, we look forward to a coordinated strategy for basic and clinical science, along with a number of health services research, which actually provides a lot of data and that helps in reducing the global burden of eye disease. So moving on to the next one this is the National Eye Institute, our view of international research. We definitely believe that global science is very interconnected, and we are very actively involved in global research. We seek scientific opportunities. We identify shared priorities and support unique programs. We also, big mission is to support U.S. Domestic grantees to expand their international collaborations. And you have many of the U.S. Scientists joining us this evening. So we also form partnership among scientists, governments, companies, NGOs, and so on. You have many countries, many organizations that are working with us at this point, and many of them, they fall into these categories. And one of the messages which I like to get across here is anyone from any country around the world can apply for NIH grant. So this is just to show you here a nice graph that over the last many years, there's been decrease in percentage of exclusive domestic scientific publications, and consequently there's an increase in the total annual output that scientific papers that actually include international collaboration. So clearly the scientific, most of us, we know the scientific impact is typically greater when research groups collaborate and benefit, and this all strengthens when we have co-authorship that are internationally located because of many, many unique information that comes and gets shared with us. So this actually gives you an idea of our own last 7 years. Our programs have grown from 32 plus programs, projects to all the way to over about 500 of such connections and program contacts that we are working with, and close to 49 countries at this time. So this is clearly a long journey, but it's clearly shows a very nice trend that how international work has become very important in the last several years. And this is just a number that, there are actually a number of about a dozen grants, which are direct grants from National Eye Institute to foreign institutions. And there are about 200 plus minus 10, which actually changes every year. This is about that number of US PIs, US investigators that have foreign collaborations. So this is a nice growing trend, and it also tells you that how we are active and actively involved in international collaborative research. Give you some examples. There are a number of research collaborations with the National Eye Institute has a direct program. We work with a number of different ways. Some are parallel funded, some are in intramural programs, some are collaborations in extramural programs, and in between. So we have programs with China, India, Brazil, Ireland, Israel, Germany, and there's new programs are developing. One is coming on this year is with Nigeria. And, in addition to extramural collaboration and intramural collaborations, we have, a number of fellowships, short-term fellowships that have been happening for the last 5-6 years. These are a month-long genomics fellowships. These are for lower and middle income countries. So we have a number of fellows who come and join us. ICO fellowship we recently started. These are a year-long fellowship. A clinician comes at a junior level and works with our scientists in our facilities. We have collaboration with Japan that has resulted into a large consortium called Global Eye Genetics Consortium. And then we have a number of postdoctoral training program. Currently, we don't have anyone from ASEAN, but we have many countries represented at this point, and we would like to actually provide and have opportunity to host ASEAN postdoctoral fellows as well. And similarly, we have visiting fellows that are working with us and come around to NEI. So here, in terms of, as I said, postdoctoral fellows, there are about 90 plus postdoctoral fellows that are working in our intramural laboratories, and there are many postdoctoral fellows that have actually been trained at NEI in the last 10-15 years, and they have actually gone back. Many of them have gone back and started their own laboratories, and that provides a very nice collaboration working with these scientists around the globe. And in terms of ASEAN, this proposed ASEAN countries collaboration, this all started in about 2018, and here's Dr. Paisan here speaking at a Global Eye Genetics Consortium program that we did at World Ophthalmology Congress, and a couple other ASEAN scientists that were part of it. And so a number of, and since then, I think, Dr. Paisan and us, we began, informal discussions, and the groundwork is essentially being done at this point, and some very dedicated champions who have come into the picture to work with us and support this ASEAN collaboration. And next step will be to grow extramural programs and collaboration in all areas of vision research, as well as explore intramural programs with ASEAN countries. And I'm delighted to say that the number of NEI, National Eye Institute, intramural faculty and associates are also on board here this evening, and they are very interested in actually working with the scientists and establishing collaboration in the ASEAN countries. So we all look forward to, and as Dr. Chang said, that we will look forward to establishing fellowships. And as you can see here, some pictures, the Thai NIH and then the ASEAN scientists and so on. And then there has been an effort of Global Eye Genetics Consortium. There are 3 volumes of these Advances in Vision Research Program books that have been produced. And I'm delighted to say that, there are a number of ASEAN scientists that have actually been part of it. So I think, we have informally began some program, and we need to expand and look into extramural areas. Okay, so some final thoughts. So NEI supports the entire research continuum, and we look forward to many opportunities to work from basic discovery into clinical applications with the ASEAN scientists. And we look forward to working with the various organizations, the government labs and associations and institutions and NGOs and so on. And as in this session, you will hear the art and science of various NEI programs and how NIH grants are, what the different procedures are, what different programs are, how they are reviewed. And my next speaker here will be Dr. Newhold, and she will be followed by Dr. Sita Bhagwan, who is going to be talking about the NIH review process. So close here by saying that good eye research anywhere is good eye research everywhere. We believe in this, and we really believe that this association and new collaboration will really bear fruits very soon, and we look forward to that. So thank you so much, and we're going to move on to the next speaker, Dr. Newhold, please. So I'm going to sign off. Let's see, stop share, and invite Dr. Newhold to join.
Okay, I'm Lisa Newhold, and I'm a program director at the National Eye Institute. And I manage a portfolio on basic biology and biochemistry of photoreceptors. And I'm also the program director for international vision research. And I guess this is the introductory slides in the U.S. ASEAN Symposium. And one of the questions for the outline is, first I want to talk about how can your program director help, and who the NEI program directors are, and what are some of the special programs, and then what is the advantage of being an early stage investigator, and then the role of the National Advisory Eye Council. So how can your program director help? One of the things they can do is to determine if your basic concept is a good fit with the mission of the goals and objectives of the Institute. You could also call to seek advice concerning project design and what is the appropriate mechanism that you should be applying to, and to talk about maybe specific trends and methodologies, and identify possible limits to the duration and budgets. You can talk about not just the mechanism, but how much money you should ask for. And also, importantly, is to discuss the review of your application to help guide you into writing a better application. On the next couple of slides, I just have listed some of the program directors that you can contact for questions. For example, George McKee works in cornea. Tony Gover is working in the bioengineering and technology, and there are 4 retinal program directors: Tom Greenwell, Ray Shen, myself, and Chuck Wright, and Natalia. There's 5. And then there's Humam works in lens, and Sherry Wiggs works in myopia. So you can go through here and see who the program directors are. And we also have programs in training and small business and looking at informatics and various things. We have a nice program too for clinical research, and there are 4 program directors that you could talk to about clinical trials and the clinical research that we have going on. And then I'll talk about, there's some special programs that NEI has started over the last, 5 or 6 years. And I was going to talk about these. The 3 programs, one of them is called the Audacious Goals Initiative. Another one is the Anterior Segment Initiative, and then the Microbiome. The Audacious Goals Initiative, just a second. The goal of that is to restore vision through the regeneration of neurons and neural connections in the eye and visual system so that the cells of the retina that have been damaged by disease or injury can be replaced by healthy cells. And through this, we funded 3 big projects. One was on imaging, the other one is a discovery-based project, and the other one is generating models of eye disease. The imaging project is to develop, the goal was to develop non-invasive imaging techniques to image functional changes in live cells of the retina and the optic nerve. And the technology is used to test the effects, hopefully will be used to test the effects of new regenerative therapies for eye diseases. And this was released as an RFA, and we funded 5 applications from that. And then for discovery-based projects, that goal of that was to identify biological factors that affect neural regeneration in the retina and identify cues, for example, identify cues that guide axons to appropriate targets in the brain, allowing functional connections to be established between the eye and visual processing systems. Again, we released an RFA, we funded and funded 6 applications. And one of the big successes that came out of this project was that was something that happened with optic nerve regeneration. And I included this because this was pretty interesting. And what they showed in this study was that visual activity regenerates neural connections between the eye and the brain. And they demonstrated that the visual stimulation helps rewire the visual system and partially restore sight in a model of optic nerve injury, most commonly used to study glaucoma and other optic nerve injuries. And what you can see in this picture is that you can see the regenerating mouse retinal ganglion cell axons, which are in the magenta and the green. And over in the left side, you can see the site of the optic nerve, and then you can see the regeneration of the optic nerves. So that was one of the successes that came out of that project. And then models for eye disease research. Models that recapitulate human disease are essential for predicting the success of therapies in humans. And there were some, the goal is to develop new disease models that mimic important aspects of eye diseases and eye physiology, including light sensing cells and looking for pathways connecting the eye and the brain region. And this announcement was released back in 2017, and it's recently been released again. And from this, we funded 5 teams to develop models in ground squirrel, tree shrew, and non-human primates, including marmoset. And then recently, NEI started a parallel initiative to address challenges in the anterior segment. This initiative is pretty parallel to the AGI because the AGI one was very successful, so they wanted to do this for the anterior segment as well. Let's see. Anyway, the anterior segment is in the front of the eye and includes the cornea, iris, ciliary body, and the ocular lens. And disruptions in the health of the anterior segment manifest in a variety of ways, including dry eye disease, ocular pain, Sjogren's, and uveitis. And a request for information to seek advice from the scientific community to help identify the gaps in knowledge was released. And we received a lot of input from that. From that, we had 52 responses that represented more than 200 stakeholders. And we had several responses had multiple signatories, and several respondents wanted the NEI to support more work on the effects of inflammation, ocular pain, dry eye, and the microbiome on eye disease and health. The anterior segment initiative we doing in 3 ways. The first was to release the request for information to the community. And then we did a portfolio analysis, and then followed by strategic planning on how to implement the suggestions from the community. So where are we with these initiatives? The one on inflammation, we're putting together a workshop on the immune system and eye health to chart a path forward in gaining an understanding of the principles of homeostasis, the disease state, and its resolution in the anterior segment. In ocular pain, we have developed a notice of intent to publish on ocular.
Aku kayaknya nggak detail ya jelasinnya ya, pokoknya.
I can hear other people talking.
Tapi malu-maluin banget.
The ocular surface from cell types to circular circuit function, and focus on the cornea, sensation, pain circuits, and hearing reflexes. This notice that was released, the announcement aims to explore the systems at 3 levels of analysis: morphologic, molecular, and functional. The premise of the funding announcement is that such basic biology knowledge will facilitate a deeper understanding of the resultant pathophysiology, including neuropathic ocular pain and dry eye disease. And then for dry eye disease, the thing that came out of that is that we wanted to identify biomarkers to diagnose dry eye disease early on. And so the purpose of that is to inform, the announcement was released to inform potential applicants of what our interest is in identifying new biomarkers for early diagnosis. And then another thing that came out of the request for information was to look at the microbiome. And the microbiome needs to be characterized on the ocular surface in order to understand how the microbiota can contribute to eye disease. And proposed to develop we wanted to develop an open resource to characterize the ocular microbiome communities and how they are elaborate in healthy individuals. And the problems with low biomass tissue, as we were discovering, is that there's a high risk for potential artifacts associated with the various sequencing technologies. And the NEI is planning to host a workshop on standardization of these methodologies before further developing the concept. And the next part of the talk, I was basically going to address the difference between an early stage investigator and early established investigator. An early stage investigator is a new investigator who has completed his or her terminal degree within the last 10 years and has not successfully competed for NIH funding. An early established investigator is somebody within 10 years of their degree, of their first substantial independent competing R01 degree as an early stage investigator. And these are important to know if you fit into these categories, because that can also affect the way your applications are reviewed and where you fall on a funding pay line. So you need to, I said, keep the profiles up to date, and the links are down here in red. Some of the benefits of early stage investigator is that special considerations are given when looking at publication record and preliminary data, so you don't have to have as much preliminary data. Focuses more on the approach rather than a track record, and summary statements are generally released a little more quickly. And they're, the differential pay plan are usually treated a little more generous in funding. An NIH grant application goes through 2 levels of review. One is through the Center of Scientific Review, and it's assigned to a scientific review group. It's often referred to as a study section for peer review, and they review it and write up a critique on their point of view. And then the second level of reviews, when the applications then, the reviews then go to the National Advisory Eye Council. And usually those are ones that go when there's specific things that need to be talked about. The National Advisory Eye Council is referred to as a second level of review, but it's not a second scientific review. The National Advisory Eye Council basically advise, assist, and consult with to give recommendations to the NEI director on matters related to funding decisions and providing a second level of review for proposals. And with that, I ask questions.
Yeah, thank you very much, Dr. Newhold. Really nice for you to actually outline all our, many of our actually external programs. So at this point, can you hear me? Can you all hear me?
I can hear you.
Okay, very good. So I'm assuming others can hear me as well. So at this point, we have a couple of minutes. We also have Dr. Michael Steinmetz, who is the director of our extramural science program at National Eye Institute. And he's listed as a co-speaker. Dr. Steinmetz is available. If there are any questions, you have two choices. Number one, we can give you minutes to ask any question or raise hand, or you could actually put your question in the chat room. And I would like to request Dr. Steinmetz as well as Dr. Newhold to actually look into the chat room and answer questions that may be coming. So if that is okay with everyone, and if everyone is comfortable using the chat room for a question, we can actually move to the next speaker. So thank you, Dr. Newhold, again. And I would like to introduce and bring Dr. Sita, who is the project for the international programs. She is at CSR, we call it the Scientific Review Program Center at the National Institutes of Health. And Dr. I'm assuming you're ready, and can you do your share screen?
Sure.
First slide. Thank you very much. Yeah.
So thank you, John, and everyone for giving me this opportunity to talk about NIH peer review. I'm apologize, I had to start a little later. So as John mentioned, I'm the Fogarty Review Coordinator, overseeing NIH peer review of several international initiatives. And I'm also a Scientific Review Officer of the International and Cooperative Project Study Section and other special emphasis review panels, primarily to review applications that are supported by Fogarty and its IC, its partners within NIH and elsewhere. And some of my previous experiences are just written there. I'm not going to go into them except to say my background is as a neurobiologist in learning and memory and Alzheimer's disease research. And I came from Georgetown as a postdoc to doing a biotech lab. I led that, directed a FDA study before I came to CSR, Center for Scientific Review at NIH. So let me move the slides. So I'm sure you've heard enough about National Institutes of Health and what its mission is, and you're aware of it. So the only point that I do want to make in my presentation is that what sets NIH apart from other biomedical agencies, both domestically and abroad, is that we separate programmatic administration from the review administration. Namely, that any proposal that is solicited for a particular program and then funded is handled by the program division, and the scientific review of an application's merit is handled by a different entity. So, for example, of the 27 NIH institutes and centers, 23 3 of them actually do solicit proposals for a funding announcement, and then they fund them post-review based on the favorable scores, identifying the most meritorious applications worthy of NIH support. And some of them also have a small review branch, primarily to review some special initiatives, which are far and specific to that institute and high priority. But the vast majority of applications are actually reviewed in this center, which is highlighted in green, Center for Scientific Review, or shortened to CSR, which is where I'm housed. And it has 2 unique features. All the applications that are submitted to NIH, and including some other federal agencies like the FDA, are received within the Division of Receipt and Referral, DRR, within CSR, even if they are reviewed elsewhere. And then the CSR center, the review committee, the organization reviews only applications. It doesn't solicit proposals, doesn't fund them. And the Fogarty International Center, and you'll hear more about it after my talk, and you may have heard also from Dr. Kilmarks at the beginning, is that they are unique in that they don't, just as CSR doesn't do funding, Fogarty is unique in that it doesn't do review, but it primarily co-funds applications or funds applications that are aligned with their program priorities with international partners and objectives. So it's just skipped somehow. So there are 3 major timelines. I hope you can all see the full slide there. So the process of submission to review to funding has 3 overlapping cycles. So the applications are received in the winter, they get reviewed in the summer, and then they are awarded in the fall. And then you have 2 subsequent cycles as it is depicted here. And you can learn more about it. These slides will be shared and you can look at those links to get more information. So I'm going to move to the next slide, primarily to focus on the Center for Scientific Review, because that's where the bulk of the review occurs, as I mentioned, and which is pretty much the same guidelines that every other institute that reviews a minority of applications also adhere to. So the main mission is to provide fair, independent, and expert reviews in a timely manner without any undue influence. And so, as I mentioned earlier, we receive all the grants within our Division of Receipt and Referral, and then we assign them to both a funding institute and a review branch, where the applications fit the focus of that review branch and handle the merit review. And so, since we do primarily only review, we have about 250 and more scientific review officers who are PhD scientists, many who have had my career trajectory, either come directly from academia or move into big pharma or small biotech and then come in. We utilize about over 18,000 unique reviewers every year. We have over 200 chartered or recurring review panels, which meet 3 times a year, according to that timeline I just showed you. And then we have about close to 1,500 annual review meetings, far more this year, and greater than 75% of the applications, about 83,000 to 85,000 applications are reviewed per year by Center for Scientific Review. And as Lisa mentioned, that applications are submitted for review, and reviewers are able to, applicants are able to identify which review panel would be appropriate. They can add an assignment request form, request specific expertise, and also mention the kind of expertise needed. However, they can never suggest specific reviewers, because that would be tantamount to leading your review. And as I said earlier, we keep review separate from any other aspect to avoid undue influence. And obviously, program officials are a great resource to help you, as well as our NIH reporter. And again, these slides are available, so you can look into the link information in these links in far more detail. And I just want to highlight that we have, this is how CSR, Center for Scientific Review, is structured in terms of review divisions. We have a neuroscience, AIDS and behavioral population, basic, physiological, pathological, translational, clinical, but there's a lot of overlap. And I'm just pointing one out. Within each of these divisions, you will have review groups. For example, the Brain Disorders and Clinical Neuroscience Review Group. And within each of these 5 or 6 review groups, you have several study sections or chartered panels, which meet 3 times a year, and several ad hoc special emphasis panels, which are created de novo to review topics and programmatic special initiatives, as the case may be. And since this is a vision symposium, I've just given you some examples of biology and development of eye study section, neuroscience of basic visual processes, pathophysiology of eye disease. And you can see how, if you go into these links, you will be able to see the roster for the last 3 rounds, the kind of topics that are reviewed there, so you get a sense. While you may suggest a study section or a panel or expertise, the ultimate decision on where the application is reviewed and by whom is up to the scientific review officer, who is the designated federal official of these review meetings, which are closed to the public. They are federal meetings. They are dictated by very stringent guidelines. And as I mentioned earlier, the scientific review officer is somebody who's come with an academic background and has an MD or a PhD and has done academic research, so understands and is the perfect liaison, like a CEO, between the academic community and the people in NIH who are administering the funding decisions. So the SRO, as they are called, Scientific Review Officer, recruits reviewers who are authorities in the field and have a demonstrated record of productivity and active funding, not necessarily always NIH, though preferred, but also other agencies, and are leaders in the field with professional societies and so on. They are, we also make sure that there is a good representation of various universities, gender, minority, so that the impact of an application and the merit of an application is assessed more broadly and by a wider audience, so that you don't have an undue influence again of a select few reviewers or a select few institutes. So we do have legally mandated restrictions that we can never have 2 people from the same department of within an institute serving on a given panel as a voting member. We could have 2 people from an institute, from the same institute, called a dyad, but even that is limited on the voting panel, because we can only have about 2 people from one institute for a given meeting, and approvals are required for it. So then we select a chair among this panel, we guide them, we train them on how to be impartial. Of course, we select people who are leaders, who can do this and who have respect in the community, but we also want to make sure that we give them the review guidelines, and we do the same with the reviewers. We train them, we assign them applications, we give them all the conflict rules and regulations. And so once the reviewers are picked, they are given the applications in 6 weeks before a meeting, 5 to 6 weeks before. Then they are told to evaluate them based on the significance of the project, the quality of the investigative team and the environment, any innovative aspect, the methodological approach of the and the study design, the scientific rigor of the study design, whether it's reproducible, and then to score it between 1 and 9, where 1 is a perfect score with hardly any weaknesses, and 2 and 3 may have some negligible ones, but still the application is of very high impact and capable of exerting a sustained powerful influence on its research field. And then if you have a balance of of strengths and weaknesses in these 5 criteria and the overall assessment of how this would have an impact. It could be scored between 4, 5, and 6, depending on how the strengths and weaknesses balance out. And if the weaknesses override the strengths, it could go anywhere between 7 and 9. And we have some other review considerations as well, like the protection of human subjects, inclusion of sex, race, age across the lifespan, appropriate use of vertebrate animals if it's an animal study, management of biohazards. And then we do not discuss budget until all the panelists in the meeting have already given their final votes. And then we talk about budget only in relation to the scope of the project and justification for the personnel and equipment requested, because the funding decisions are determined by program, and they will just take the budgetary considerations into account. But really what they want from the review committee is whether the application is of high impact based on their programmatic interests. Now, as I mentioned earlier, we are guided by legal review guidelines that are very specific to NIH. And when I have done joint review with other countries, even though they too have confidentiality and conflict rules, ours are far more strict in that we cannot have any recording of our meetings. We cannot have any communication between the members. We have far more stringent conflict of interest rules. I'm not going to go into details, but they are there for you to look at. And then in terms of once we've vetted all that and gotten signed agreements, we ask the reviewers to come together in a day, 1 or 2 or 3 day meeting. Previously, we used to do them face-to-face, in person. Now we do mostly Zoom. Each application is assigned to at least 3 people, and they will present in the panel, and then they will give an initial score and present their point of view, and the rest of the panel will then vote accordingly. And that's how it looks. And we review about 70 to 100 applications within a day or 2. We have anywhere from 12 to 22 to even 35 reviewers in a meeting. That's how they sit around if it's a face-to-face. We typically discuss the top half of the applications. And as Lisa mentioned, if they are new investigators, we cluster them separately to level the playing field. And again, I'm not going to belabor these points. They have been said and they're available for you. And so once the panel votes on it, we average their final impact score or assessment and multiply that by 10 to get a final priority score. Some of the NIH institutes request a percentile. We'll give them a percentile so they can rank them. And then we provide a summary statement where the SRO provides a resume of the panel discussion with the priority score and all the full critiques and comments from the assigned reviewers with their criterion scores. So both program and the applicant have that information. And then it goes to the second level of review that Lisa mentioned. So that's the overall time frame. And I believe that's mainly what I had. And these other slides are just, again, links. I hope I have kept within the time and I didn't take away anybody else's. I will stop here, and if there are any questions, I'm happy to answer them either via chat or even later offline. Thank you so much. I'll stop sharing the screen now.
Thank you, Dr. Seta, and thanks on behalf of Fogarty for all your support for the review, the excellent review of the applications that we received. It's now my pleasure to introduce our next speaker. Michael Cheatham works with us in the Fogarty International Center. He supports the software, the mapping tool that he will talk about called World Report. He's been with us for about 3 years, and prior to that, he worked with NIBIB, the National Institute of Imaging and Bioengineering. And he's very experienced in supporting international collaborations. So we're delighted to have him give you an update on World Report. Over to you, please, Michael.
Thank you very much, Peter. I put a summary of that bio on that first slide. Let me see if I can get my slides to advance here. So I'd like to talk to you about World Report, which is a resource that is available to the public for visualizing and interacting with data pertaining to global biomedical research. World Report has been around since 2012 and has been in a startup mode for several years. And it's currently a consortium of 12 funding agencies who pool their data in a common format. And I'll explain some of the utility of that as I go along. So what I'll do is give you a very, very top level overview of what international represents to global research networks supported at NIH. Looking at ASEAN countries over a 5-year period, we get a pretty quick snapshot that the region as a whole is very engaged in NIH-funded research. 9 of 10 ASEAN countries participate in NIH-funded research, either as direct grantees or as collaborators, international collaborators with a U.S. principal investigator. And you can see the breakdown there. Right. World Report is very good at getting up to speed quickly at what you need. So here is another breakdown of who at NIH is active in research collaborations in the region. 21 of 24 grant-making institutes at NIH are engaged in almost 2,000 records in 9 countries. There are about 500 unique grant activities underway over the past 5 years in almost 200 research organizations in the region. And when it comes to NEI, there are 10 unique NEI research programs that have been active in the ASEAN region over the past 5 years. So again, the data is very easy to manipulate and interact with. And if you have an inkling of who might be the most prominent institutions who are engaging in NIH-funded research, you can generate visualizations such as this, which show the relative size of the rectangles in terms of number of research activities they participate in. Looking at NEI's collaboration in ASEAN over this same 5-year period, World Report will show you 25 research records. Again, I've pointed out that that's on 10 unique projects, but projects that run in multiple years will generate duplicate records. That's by design. They span 2 countries in the region, and they are spread among 6 unique institutions. The top half of the World Report screen is a map-based interaction, and the bottom half of your World Report screen is data. Now, the data side of your screen, I would also point out, is also interactive, and specifically, I would call your attention to the right-hand side. World Report does not aspire to be the beginning and end of all information resources on NIH-funded activity. It simply acts as a gateway to get you to the definitive record. So through any record that you find in World Report, you can click through, read a little bit about the program, who the principal investigator is, and what research institution is being supported. But you can also find out who the collaborators are, and you can read the abstract submitted for that project. And I point this out because this turns out to be very useful information for users in World Report who are seeking either collaborators in their field or who are seeking funding opportunities. One of the more successful ways to break into the world of NIH-funded research is to partner with an established investigator. So this is a slide that Prakash shared earlier, and I just wanted to highlight the trajectory that NEI is on in terms of the importance of national program collaborations in their vision portfolio. And you can see the tremendous growth. And again, through World Report, you can interact with all of this data in some detail. Finally, I will just end on my promotional slide. What is World Report? Well, it's a visualization of direct awards and indirect research collaborations from a dozen biomedical research funders. At present, it's a little over 500,000 funding records, 195 countries and 25,000 institutions. Why do we use it? Well, it's a very simple tool to understand the research landscape in a country or region. Other users look for collaborators. I know the Center for Scientific Review sometimes uses it to identify reviewers for their panels. The policy community can look at World Report and see where the funding is going for a particular disease burden or condition. But we're most interested in how you use World Report, and we're eager to get your input. World Report is undergoing a major technology upgrade in the next year. The site that you see there with that worldreport.nih.gov is something of a placeholder, but over the next year, World Report will become integrated with a very powerful suite of analytic tools developed at NIH called iSearch Analytics, and World Report will be the international module that will allow you to interact in great detail. And I would close by just calling your attention to some of the logos on the bottom of your screen. These are the 12 funding partners who currently share their data with us. So we find it as a very useful resource within NIH to establish contextual information. Who else is funding research in this particular area? And again, that crosses over quite nicely to the principal investigator world, to the grant seeker, because they can find out which funding organizations are interested in funding work in their particular area. With that, I would wrap up, and I think I hand it over to Peter.
Sawadee ka tukon. Chura nai pet Peter Kilmarks, Rong Po Amduikan, Sunanachat Fogati, Sataban Sugapap Hengchat Saharat America. Delighted to be here, and thanks to my co-host, my co-chair, John Prakash, for inviting me, and just want to thank the NEI director, the ambassador of Thailand to the US, the US Chargé d'Affaires, and the Minister of Public Health and Deputy Prime Minister, all protocol observed. I've got some slides to share. Good, so I'm just going to speak from the perspective as the Deputy Director of the Fogarty International Center about more broadly the support from NIH for global health research and capacity building and training. And the main message that I want to give you is that NIH is very supportive of global health research. Our director, Dr. Francis Collins, when he came to NIH in 2009 and asked about his priorities, one of his top 5 was about expanding global health research in diseases affecting the developing world. And I think Michael showed in his slides about World Report how that we've really seen this expansion of international collaborations in global health research in the last decade. So one might ask, why is the NIH interested in pursuing global health research? And I've listed here, there's really quite a number of reasons, really strong scientific justification and opportunities with unique populations around the world, different disease presentations, genetics, different exposures and environment, whether it's infections or diet or cultural context. And then also there can be unique interventions in frugal or novel technologies, mobile health, unique insights and expertise of investigators around the world. The best science and the best scientists aren't all in the US. And then for some conditions, rare conditions, there can be large, potentially treatment-naive patient populations that can be accessed through global collaboration. And then also alternative health systems are of interest for our research. So this is a publication we looked at. Of all of the publications that are funded by the NIH, we asked what percentage of them have a global collaboration. And what we found in 2017 is that fully 35% of all NIH-funded publications had a non-US affiliated co-author, and those with both US and non-US co-authors had a greater mean citation impact score. So clearly the NIH-funded research is a global enterprise and it's high impact. It actually has a higher citation score than the papers that are US authors alone. If you look among all countries, which countries have the highest number of these papers, it's actually China. It's now #1, or as of these data in 2017. And if you look among the low and middle income countries, here's Thailand is actually one of the top countries where there's collaboration and co-authorship on US funded research. As for the Fogarty International Center in particular, we're one of the 27 institutes and centers at the NIH, and our mission is to both support all of NIH in their global partnerships and research, and then specifically with our resources, we support training and capacity building in low and middle income countries. And so we really have a very broad number of activities and scientific areas. Over 6,000 scientists worldwide have received training with support from the Fogarty International Center. There's more than 400 ongoing projects with more than 100 academic institutions. And we've gone beyond sort of tropical medicine and infectious diseases, although that's still very important. There's also other the chronic conditions, informatics, mHealth, bioethics. We do have an active portfolio that NEI collaborates with us on in brain and vision research. So it's really quite a diverse areas of research. I do want to note, in addition to what Michael Cheatham presented about the number of extramural collaborations in the ASEAN region with the NIH, there's also the intramural program at the NIH. I think Dr. Prakash showed this picture of the clinical center, which is the world's largest hospital dedicated to medical research. And there's an NIH intramural research program with nearly 6,000 scientists and about 10% of the NIH budget. So working at NIH from the ASEAN region, there's over 30 scientists, and you can see from these countries that are working with us. So this is another way that we collaborate globally. Just to underscore the support and interest from our leadership, Dr. Francis Collins and also the Fogarty director, Dr. Roger Glass, traveled to Thailand in 2016, and here they are meeting with a number of Thai scientists. I don't know if some of you in the audience recognize some of these folks, some of these collaborators. This was about genomic research. And then they also, during that visit, had the honor of meeting with Her Royal Highness Princess Siranthorn, also in Thailand. And so just to wrap things up, I just want to thank everybody for the participation and really to emphasize how much NIH, the Fogarty International Center, and NEI value our global collaborations and the scientific opportunities that we see there. I would encourage you to subscribe to the Fogarty. We have a general newsletter and then a funding newsletter that comes out every week and highlights funding opportunities, not just from Fogarty, but also from other NIH institutes and also from other funders of global health research. So it's sort of a one-stop shopping for funding opportunities. And then you could also follow us on Twitter and on Facebook. So again, Sawadee Kap, Kapun Kap, and I hope to see more collaborations from the ASEAN region going forward. Thank you.
Okay, so thank you so much, Dr. Marks. This is a very appropriate comment that clearly shows NIH's commitment, not just NEI, but also NIH commitment to international collaboration and, in not only in basic science, but clinical science, clinical applications, health sciences research, and all around. And clearly, National Eye Institute is committed to actually working with not just ASEAN members, but collaborators all around the world. So you and Michael Cheatham has beautifully summarized all NIH-wide data, which we're delighted with. So thank you so much. Now, we have a couple of logistics session. I was just speaking to Dr. Mitch Brinks, and Dr. Brinks and I just discussed this, that we are going to have a little bit of extra time in terms of break. And the schedule is running a little bit ahead of time simply because the web audience could not see, could not hear the session one speakers, our distinguished guests. So that's okay. We have gained some time. And so there are two things before I close this session. Number one, there seem to be two channels here. One is for the speakers and the other one for the entire web attendees. So the speakers, on the speakers channel, we are not able to see the questions in the chat room. And we accept it. That's a technical fault. And we accept it. And I have, Dr. Brinks and I have just discussed offline. We just discussed that, we're going to allow two ways to answer questions. Number one, that you had in my slide, you had my email, which I'm going to spell it again for people who are actually writing it and who are asking questions. I'm going to give you my email address, and please forward your email to me. And my email address is gyan.prakash, Prakash, at nih.gov. Okay, so that's that. And I would also, one of our speaker, Dr. Lisa Newhold, she's co-speaking our presentation with Dr. Michael Steinmetz, my colleague. And Dr. Michael Steinmetz was and is available in the chat room, and I believe he's answering questions as well. But unfortunately, those questions he was able to see only coming from the other speakers. So for the general web audience, and Dr. Steinmetz, please allow me to share your email address if it's okay with you. It's on the NIH webpage. One can get it from NIH webpage, or I'm going to spell it, which is STEINMMEM@nei.nih.gov. So please forward your questions to either to me, I'll forward them to the correct panel speaker, or if you have any program related questions, NEI's extramural program related questions, please send them to Dr. Michael Steinmetz, my colleague. So thank you very much for that. At this point, we're going to actually close this session. And before I do that, I want to thank my session speakers, Dr. Newhold, Dr. Bhagwan, Michael Cheatham, and Dr. Kilmarks. And then special thanks to Dr. Kilmarks for co-chairing this session. And also I want to appreciate the opportunity that we have received and we have had from my organizing or the organizing committee, Dr. Mitch Brinks, Dr. Paul Chan, and of course, Dr. Paisan. And I just also want to mention one more thing here, that clearly Dr. Paisan and I started discussing this collaboration, and I showed some pictures of Dr. Surakomet and his genomics lab at NIH, Thai NIH, and clearly there was some good discussion that has been going on, and I'm delighted to have actually formalized and present this session working with my distinguished colleagues. So thank you very much. This is the closing of NIH session. And at this point, we have approximately 15 minutes of break. And so let's take a 15-minute break. Many of us are actually East Coast in the United States. and it's obviously either a break time or dinner time. So that actually works out quite well, a 15-minute break to grab something to eat quickly and then come back to and have a very enjoyable and productive evening with our ASEAN colleagues. So thank you so much, and we'll see you exactly at 8:25 East Coast time, PM, and 8:25 the Thailand Bangkok time. Okay, thank you and very much.
Welcome back from the break. So we will move on to the next session. Next session will be a keynote presentation, Opportunities for Advancing Visual Health Research and Education. So please welcome the chair of the session, Dr. R.V. Paul Chan, Chairman of Department of Ophthalmology and Visual Science, Illinois Eye and Ear Infirmary, University of Illinois at Chicago. And the co-chair of this session will be Dr. Paisan Ruwamibulsuk, a chairman of Department of Ophthalmology, Radviti Hospital, College of Medicine, Rangsit University from Thailand. Please welcome.
Dr. Paisan, and it's an honor for me to be co-chairing this session with Dr. Paisan, my good friend. For my disclosures, as I am also Thai, so it's great to be here. I'm sorry that we all can't be in Thailand together. Our first speaker for this session, who really needs no introduction, but Dr. Brinks introduced him so nicely already, is Dr. Michael Fred Chang, who's the director of the National Eye Institute. Just to give you a little bit more background about Dr. Chang, he is an expert in pediatric ophthalmology. That's his training. But what he's really made significant ground on is development of assistive artificial intelligence system for ROP that recently received breakthrough status from the U.S. Food and Drug Administration, and leading the imaging informatics for ROP consortium. He's published over 200 peer-reviewed papers, and just looking at his training, he received the BS in electrical engineering and biology from Stanford University, then went on to Harvard Medical School, completed his fellowship and ophthalmology residency at Johns Hopkins Wilmer Eye Institute, and then joined the faculty at Columbia University, where I met him over a decade ago. And most recently, he was at the Casey Eye Institute at OHSU. Now serving as the National Eye Institute Director, Dr. Chang, thank you for being here.
Paul Paisan, thank you very much for the introduction. Paul, I think you underestimated. It's been about 15 years that we've known each other. And you know, it's really a pleasure to be able to be here with all of you. Again, let me share my screen. I'm going to talk about artificial intelligence. And because this has become a really hot topic, and it's an area for a lot of potential collaborations between the U.S. and ASEAN nations, and it's also something that I've had a little bit of collaborations with with Paisan recently, and so we'll talk about a little bit of that work. I mean, I've been really fortunate to have done some of this work with people like Pete Campbell. And with Paul Chan, and again a little bit with with Dr. Paisan. So we'll talk about accomplishments and gaps in knowledge. And I hope this will inspire people to think a little bit about potential for collaborative research in this area. So the disease that I've gotten interested in working on has been retinopathy of prematurity. And I'm going to try to make points, though, that are generalizable across any diseases. So ROP is going to be the disease that we use as the example, but try to think about areas how this could apply to specific areas that you might be interested in. So why does ROP matter? It's one of the leading causes of childhood blindness worldwide. Big problem in ASEAN nations. And there are 115 million babies born per year, of whom about 15 million are premature. Now, of these babies, almost 200,000 a year are developing significant ROP, of which over 30,000 go blind or develop significant visual impairment per year. almost all these cases of blindness are preventable if they're diagnosed early and treated appropriately. And that is the challenge because in a lot of developing countries, the ophthalmologists and the neonatologists are not as used to managing this disease. And so it's a bigger and bigger problem. Now, even in the US, we have a lot of challenges in taking care of babies with ROP. The way that we diagnose it is that we do an eye exam, ophthalmoscopic exam. And if the baby has something called plus disease, the baby's at risk for going blind and needs to be treated. Okay, so we've got to diagnose that accurately. And what plus disease means is that you have tortuosity of the arteries and dilation of the veins in the retina. Okay, now the challenge is that even world experts in ROP are not very good at diagnosing plus disease consistently or accurately. Okay, in 2007, we did a very simple study, which is that we selected images and put them on websites and showed them to people around the world. This image, 50% diagnosed plus, 50% diagnosed not plus. And there were a lot of images like this that split 50-50 or 60-40. And so this is a big problem. And 5 years ago, we did some interesting studies with Pete Campbell in Oregon and Jayshree Kalpathy-Kramer at Harvard. And we basically showed 8 world experts 100 images involving retinopathy of prematurity. Right? Now, in retinopathy of prematurity, you either have plus disease, really severe, and if that expert diagnosed that image as plus, the box is red. If that expert diagnosed that image as intermediate, meaning pre-plus, that box is yellow. If the expert diagnosed that image as normal, that box is green. Okay, so the first thing to notice here is that expert number 8 diagnosed plus disease 6 times more often than expert number 1. And if you go to a different set of images down here, okay, data set B, it's that same 6-to-1 ratio. Expert number 8 diagnosed plus disease 6 times more often than expert number 1. Okay, so we have overcallers and we have undercallers. And I think we all know that this is true in every field of ophthalmology and probably every field of medicine. That there are some people who are aggressive and there are some doctors who are conservative. Now, the other thing to note here is that if you take each image going down the columns, and if you give that image 1 point if somebody diagnosed normal, 2 points if they diagnosed pre-plus, meaning intermediate disease, 3 points if someone diagnosed plus, if you average out those scores and convert to a color, that's what this looks like. Okay, so the images here are very green because everyone diagnosed normal. The images here on the left are very red because everyone diagnosed plus, and there's every shade in between. Okay, so the point that I want to make with this is that the real world is a continuous spectrum of abnormality, okay, from very normal to very abnormal. And when we do clinical care and evidence-based practice, we have these impressions that the world comes in people who are normal, mild, moderate, and severe, but we don't. We come on a continuous spectrum, and we have good evidence that in ROP, we are very good. If you show the average ophthalmologist 2 images, which is more severe, we're very good at making that distinction, but we're not very good at drawing lines. Some people draw it here, some people draw it here, and that's where things like artificial intelligence systems can help. Okay, there's been an enormous amount of work in artificial intelligence in ophthalmology and really in all of medicine. And Eric Topol, one of the American thought leaders in this area, put a message on Twitter. Of all the medical specialties, most people think radiology is leading the artificial intelligence movement, but it's actually ophthalmology. Okay, now here are some examples. Okay, the first FDA-cleared autonomous artificial intelligence system was in diabetic retinopathy, and that was developed at the University of Iowa. And there's been really, really beautiful work done at Google Health and in the United Kingdom, showing that you can learn things about these retinal images, about somebody's systemic health. And you can do things like predict macular degeneration progression. And as Paul mentioned, we've done work involving diagnosing plus disease from ROP images. Now, one thing that we've done recently is move beyond. So we've made the argument that ophthalmic diagnosis is qualitative and it's very subjective. Can we use artificial intelligence to make it more quantitative and objective? And so this is one area that we've done some work in. And this is Pete Campbell, here's Jayshree, and here's Sang-Jin Kim, who was a visiting retina specialist from Korea. And so what we did basically is we took the output of these deep learning systems and we converted those numbers to a 1 to 9 scale. And so 1 means really, really normal, 9 means really abnormal, and there are all these examples in between, just like that continuous spectrum of abnormality. And why would we want to do that? Because the current way that we diagnose ROP is normal, pre-plus, or plus. That's a 3-level scale, but that's really not enough for making distinctions when you're looking at a baby. Is that baby getting better, or are they worse, or are they the same compared to your previous exam? 9 levels gives you more granularity to be able to distinguish. And so there are a lot of other benefits of being able to do this, but we've developed that scale. We've done a lot of work to validate it. And I think a lot of ophthalmology is like this. It's a continuous spectrum, and there may be some benefit of trying to quantify those distinctions. So for example, one of the retina fellows that we had worked with in Oregon, Stanford Taylor, wrote a paper last year where he looked at 5,000 retinal images and calculated that quantitative score from 1 to 9 on those 5,000 eye exams. And so there are 2 types of babies here. The babies down at the bottom never needed treatment. They never developed severe enough eye disease to need treatment. The babies who are in the darker color eventually needed treatment. Okay, so this is the 1 to 9 scale. This is time. This is your first eye exam when the babies are younger. And this is these are the eye exams two months later. Okay, and this is when the babies get treated. So you notice that the babies who got treated, the ones who didn't need treatment, of course, they had low scores on the 1 to 9 scale, and the ones who needed treatment had high scores. Okay, so that's natural. On the first eye exam, all the babies had low scores. But even a few weeks in there, the babies who eventually needed treatment started to get higher scores based on this artificial intelligence quantitative scale. And so in that sense, maybe artificial intelligence can give us more information to help us predict risk and identify babies who are at risk for progressing in the future. So maybe, for example, in countries with less resources, we could use this to pinpoint which baby needs to be watched really carefully. So a lot of potential applications. Now, when I worked in Oregon, I had the privilege of working with a couple of remarkable researchers in imaging, David Huang and Yali Jia. And they sent me these images, and because it's not just about fundus photos these days, it's about OCT and OCT angiography, where we can really detect motion and flow over time. And that opens a whole range of new possibilities for studying the retina and looking at things like artificial intelligence. And for example, Pete Campbell and Yifan Zhen have been working on moving from artificial intelligence-based diagnosis to applying those methods to handheld OCT and OCT angiography. And I think there's a lot of exciting work in the future. So this is my final slide. And I think that there are some areas for further research and potential collaboration. One of them is that these artificial intelligence systems need to be generalizable. Okay, for example, do they work across different populations? What are different populations? Different race, different socioeconomics, different oxygen management. And there may be opportunities for collaborating with ASEAN nations. What about if you use different retinal cameras or that have different fields of view? Again, we don't know the answers to those really, really important questions. We've talked a little bit about developing and evaluating mathematical risk models for disease progression based on, for example, things like that 1 to 9 scale, and a lot of potential opportunities for collaboration. And we've talked about developing and validating OCT-based image analysis in ROP. And more broadly, I know Paul's going to talk about education, and there are important challenges in knowledge dissemination, and how do we take these systems and integrate them into real-world practice. And so, I'm really excited to see, how this field turns out and whether there are possibilities for working together. So thank you very much.
Thanks so much, Dr. Chang. Our next speaker is Dr. Mark Rosenblatt. Dr. Rosenblatt will be discussing international research collaborations to enhance global health equity. Dr. Rosenblatt is the Executive Dean of the University of Illinois College of Medicine. He's an internationally recognized corneal surgeon. He serves as the Health and Wellness Lead for the University of Illinois System's $500 million Discovery Partners Institute. Also serves as Director of the Corneal Regenerative Medicine Laboratory and leads a group of scientists investigating the mechanism of corneal peripheral nerve regeneration following injury. He's been extremely well funded. He's a leader in our field. and has published over 150 original manuscripts, review articles, book chapters, and abstracts. I work with him here at the University of Illinois College of Medicine. He's a tremendous leader, and we look forward to your lecture, Dr. Rosenblatt.
Thank you, Paul. It's really a pleasure to be here this evening or morning, depending on where you might be. I want to talk about something we don't always talk about so explicitly, that is health equity and how international research collaborations might be used to increase the amount of equity that we see in health amongst populations. My disclosures, primarily that I do have intellectual property related to the use of silk biomaterials, which I will talk about during the talk. So health equity is a huge topic. It's very important. It's actually become very important in the United States recently, particularly with issues around social justice. But we know there's long-standing issues around differences in the amount of health, quality of health across not just a country like ours in the United States, but also across the world. But it really is a problem here in the US. This isn't an ophthalmology slide. This is really about life expectancy. This is in Chicago, downtown Chicago, actually where Paul lives. In Streeterville, the average life expectancy is 90 years old. So this portends great things for Paul. If you live just 10 miles south of where Paul lives in Chicago, your average life expectancy is 60 years. So even in a very wealthy country like the United States, perhaps, there are huge differences in health equity. They're profound. And we know there are many social determinants of these kinds of health, including your neighborhood, if there's violence, your health care, your education, economic stability. And so these same sorts of determinants of broader health also important in vision health. Here's an example of some data regarding the inequities across the world in terms of prevalence of visual impairment. So the highest levels of visual impairment happen in South Asia, regrettably, and the lowest seem to be in high-income North America. And it's not just those who are blind, but also those who have mild to severe visual impairment or even mild visual impairment. And so we know that there are genetic differences, economic differences, other social differences. We would hope for a world in which all these blocks would be very low, these bars would be low, and also equal, given that I think we feel that everyone has a right to see. Now, if we begin to look even within countries, it seems to be that wealth is a very important determinant, that in lower income countries, the wealthiest people in lower income countries see better than the lowest income folks. But also, we know that in general, if you're in a higher income country broadly, you'll have better vision than if you were from a lower income country, although that does change over time. The other thing we do know, I mentioned that there are social determinants of health. We know that vision health, your ability to see, actually has other social determinants itself. It's really a reciprocal sort of activity. We know that if you see better, your general health will be better, you'll be able to get a quality education, there's better gender equality, poverty, hunger, better work and growth environment, etc. Will be better, and there's evidence that demonstrates this broadly. So it's really a broader health issue that our health of our eyes are not equitable across countries. We look at the amount of research that's done into vision health, we also see inequities. So the darkest purple here demonstrate where the most vision research is happening. And we see there are some countries which essentially there are no research studies being done, and a lot in between. But you can imagine a country like the United States performing research that is very valuable for global vision. But on the other hand, we also know that we tend to take care of the problems that affect us the most. So the most research is happening in certain countries. It's likely that they're doing research into problems that may exclusively or more predominantly affect those countries to the exclusion of focusing on health vision problems that may happen in other countries. So these kinds of research that might be affected or might be applicable to global health equity isn't just in the population health realm. It's not just in the large pharmacology studies or infectious disease studies. Work in my own lab looks at translational research to treat injuries of the cornea. So here's a typical chemical injury we might see anywhere in the world. But we know that if you're in certain parts of the world, you'll have access to corneal tissue for an effective corneal transplant. So on the left, I don't expect you to see the fine details, just to say that the rate of corneal transplantation differs broadly and widely from the United States having the highest rate, all the way down to the Canary Island, to the Venezuela having the lowest. And And you can see on the right, showing the supply and demand of corneal transplantation across the world, with the United States being a net exporter of corneas, and many countries essentially having no internal source of corneal tissue. So this is a health equity issue. And I work on new biomaterials to create new corneas that can help patients with severe corneal disease. And the truth is, my work has more effect, more proximal effect on the lives of people in countries outside the United States, given that there's ample corneal tissue in the United States. We're actually using a material that you find around the world, particularly in Asia, silkworm silk. We're able to create very thin, strong films. They're transparent, that can be used to reconstruct corneas. We've actually enhanced these films by creating nano-engineered grooves on them so that we can then control the activity, the performance, the stem-like factors within cells growing on the films. And then we've been able to transplant these films back into the eyes of animals. We're not yet helping humans. But the things we're learning in these preclinical models, hopefully at some point we'll be able to help humans. And the fact is, it's probably most applicable to people in low and middle income countries that have less access to corneal tissue. And by the way, it's very, very inexpensive to make these films. Another area that's very important, we just heard a wonderful talk by Dr. Chang around artificial intelligence. I believe, and this is an opinion, that artificial intelligence may possess the greatest potential of any technology to enhance health equity. There's no bias, potentially, in artificial intelligence if it's constructed well. But there are perils, and I thought I would talk about a few of those. One is that data sets may not include data from a diverse population. So this lack of diversity really leads to a scotoma, and the AI that's developed may only serve a particular population. If you look here at two normal eyes, they look very different, and image processing algorithms, AI, might view them very differently. So the data that feeds into these algorithms need to come from a broad set of people. We know that from the work that Verily has done and others, that they've actually taken data sets from around the world to try to train their algorithms, and this has been to the betterment of their effects. In Chicago, we have investigators who are making sure that we use representative data sets that can reflect real populations around Chicago, but also I think will affect the world. We have such a diverse city. Next is the clinical application. So AI technology is applicable to almost any disease, but the bias in the selection of clinical problems may lead to neglect of key diseases. If you do a quick PubMed search, look at artificial intelligence plus diabetic retinopathy plus diabetic retinopathy over 400 days. So maybe we're not investigating that the AI industry really is characterized by a lack of diversity across our country, the United States, but also the world. And clinicians and biological scientists need to be able to have easier access, easier to use AI algorithms that don't require you to be an expert in computer science. Also access. Unfortunately, sometimes the key technology to avail oneself of AI remains a barrier. We know there's a remarkable digital divide. In the US, only 55 to 60% of people who are elderly have access to a smartphone. Low-income Americans have low digital literacy. On the right, you see an internet census. This is where the activities of the internet over a day. You see there are hotspots, and there are parts of the world really that are neglected and don't have access to good Wi-Fi or broadband. Finally, embedding AI in technology that is very high-tech is great. It makes that technology work better. But if there's no access to the underlying technology, you also have lack of access to AI. So indeed, in the Verily studies, which were partially done in India, in the urban settings, they worked very well. But in the villages where they didn't have such good cameras, it didn't work so well. So how can we drive policy? Well, research policy driven by money can make a difference. So principles I'd like you to consider. One is that research data should reflect a diversity of populations afflicted with a particular disease. We need data sets, we need research done on all people within a population. Next, we need to make sure we research diseases which reflect diverse populations of patients around the world. We don't have these scotomas, let's say, where we neglect very important world diseases because they're not affecting places where the research is being done. Finally, attention to providing access to technology by democratizing this technology, to widen its use, and by making technology more readily available. We should also diversify international eye and health leadership and researchers. This is just some data from a group who looked at the leadership of eye health groups and saw that there weren't as many ethnic minority men or ethnic minority women or women in general leading these groups, which also means that perhaps certain eye diseases, certain populations within countries are neglected. Finally, recognize how research can improve critical social determinants of health. And so I don't expect ophthalmologists or vision researchers to solve all the ills that affect the society, but we should know there are things we can do around childhood experiences, housing, education, social support, family income, etc., that will also improve vision. And I also presented to you the fact that the converse is also true. If we can improve vision in global populations, we'll also improve their overall status and quality of life. Finally, we should know that optimism is the faith that leads to achievement. Nothing can be done without hope and confidence. This is Helen Keller. I have a lot of hope and a modicum of confidence, perhaps, that we will be able to do research on a global scale that can help the inequities that we see in vision health across our globe. Thank you.
Well, thank you very much, Mark, for the wonderful lectures. Well, it's my privilege to introduce our next keynote speakers, who is from KCI Institute on Portland, Oregon, USA. Dr. Dave Wilson. He's a director of KCI Institute and Paul Casey Chair in Ophthalmology of School of Medicine of Oregon Health and Science University. He assumed the directorship of ophthalmology since 2005. Additionally, he is director of the eye pathology laboratory at KCI Institute. And as the institute director, Dr. Wilson provides the institutional leadership and clinical and academic experience necessary to continue building a program and national prominence. Dr. Wilson, in addition, is a member of many privileged societies, including the Macular Society and the American Ophthalmological Society. From 2007 through 2014, Dr. Wilson served as a director of the American Board of Ophthalmology. His primary areas of interest include eye pathology, clinical pathology, correlation of ocular disease, macular degeneration, gene and cell-based therapy, and ocular oncology. Well, I have a privilege to visit KCI Institute 2 years ago. And KCI Institute has a good relationship with ASEAN countries. I think KCI Institute has a training for Myanmar doctors, and we also have some ophthalmologists to be trained over there. And we have MOU together between KCI Institute and Sri Lanka Hospital, and also Rajvi Hospital as well. Will you please welcome Professor Dave Wilson to give the keynote speech. Thank you very much.
Well, thank you very much. A lot of the points in the bio were reviewed there. I think really the main thing that I bring to the meeting here is being at the institution with Pete Campbell and Mitch Brinks and until recently Mike Chang. It's been a really wonderful time watching the programs grow. I chose to talk about education, and I did that knowing that this was being really mostly about research, because I think a lot of research also involves education. And I think there's some wonderful academic institutions in the Asian countries. I've had the real privilege of being able to go to a couple that are shown here in Thailand, and I know that virtually it would be good to go to many of the others, or maybe even in person. And I think education can really be a linchpin in people getting exposed to research and really getting involved with programs so that they grow throughout the world. And I'm going to try to highlight that a little bit. I really think that the programs that we do should be inclusive. They should be complementary, because that really helps everyone, and they should be reciprocal. And I'm going to talk about 3 different areas where I think education can really serve as an introduction to research and even give some specifics. So when I think someone spoke about one of Francis Collins' goals was to broaden international exposure for NEI. I had more humble but similar goals when I became chair. I thought it would be good to expand our residency training to include international candidates. And the upper picture there shows Mitch with our real success in that, who now is the ophthalmologist in American Samoa. So that was the initial paradigm we had, but that turns out to be really very difficult because even the baseline USMLE scores are quite expensive to take the test, and so it's very difficult to have a very high volume program that has training at that level. What we evolved to was really a hybrid training model in the clinical area, and Mitch has really been so successful in this that involves having really more mature providers come to KC for 3 months at a time, and then they don't have any of the credentialing or test restrictive issues as observers while they're at KC, but then our faculty goes over for extended periods of time to work with them in their home country. And the bottom picture there shows a group of people that includes 2 faculty members that had come to KC, and one in the center there is an oculoplastic surgeon, and right behind her is Eric Steele, one of our oculoplastic surgeons, and they developed a very strong program for oculoplastics working together. And so I think that hybrid training model of having some in both institutions is one that's really quite valuable. Now, the other thing is that now that we're so familiar with web-based conferencing because of the restrictions of group gatherings, I think that there's a terrific opportunity for clinical teaching on region-specific diseases, which Mark alluded to in his talk, and also region-specific treatments. Now, one of the opportunities is also in public health because the causes of blindness are very different in different countries, and there's also differences in disease frequency, and that can help both groups. For instance, a disease like myopia is more common in Asian countries, but really rapidly growing in the United States, so there's great opportunities for collaboration. Same with angle closure glaucoma and polypoidal retinopathy. We've also been quite interested in screening programs, and I think those are even more mature in Asian countries than they are in the United States, as well as the use of non-physician providers. Now, one other specific that I wanted to bring up are some of the NEI programs that I think are very good potential for having direct involvement of people from different countries. The T32 grant, which Mike was successful in getting when he was on our faculty, has a regular curriculum of lectures, and it's shown there in the syllabus, which is too small to read, but there's an opportunity for many people to be in the audience to listen to the lecture, and also even to give the lectures. I put this picture for 2 reasons. One is that you can see that everybody always sits in the back of the room, so there's plenty of room if you happen to be there. But also to show Ben Sivier, who happens to be from Australia, one of our faculty members. He hasn't learned to sit in the back yet, but he's very interested in developing a hybrid teaching model in research like we do have in clinical areas. And I think that that same hybrid model would work quite well. He does clamp recordings of cellular electrodes, and that is a skill that it could be transferred, and he could assist developing similar programs. The other area of that type is core labs. I think that one of the successes we've had is with iBanking on the clinical side, but it's a very similar concept for core labs. Now, web conferencing, of course, has the problem of the time zones. So we know that everybody here is at a different time of the day, but these things can be done asynchronously. And I think that lectures could be recorded and that could allow reciprocal and complementary faculty members participating both in the research and clinical. And I do, as I mentioned, think that hybrid formula for research education could be quite valuable to all of our institutions. So those are the thoughts I had as to how education can be a springboard to involvement in research. Many of the grants that ultimately could be acquired, I think, can start out as collaborations, and I think that's something that different academic institutions are quite interested in. So thanks for letting me make some comments.
Thank you. Thank you very much, Dave, for your insightful lecture about education, which is very important. Well, without further ado, it's my privilege to introduce our next speaker. Well, actually, he needs no introduction. I think he's the pride of our ASEAN ophthalmologists. I can say confidently that he's one of the world's best ophthalmologists. Well, with more than 1,000 of publications, can say it all. And lastly, well, last year, he's just been inducted into the United States Academy of Medicine, which is a rare opportunity for ophthalmologists to be there. It's my privilege to introduce a friend of mine, the director of Singapore National Eye Center, Dr. Tien Ying Wong. Please, Tien.
Yeah, thanks very much. I think Paisan, a lot of my friends, Paul, Michael, and John and others, really glad to be here. I think, this is a very important opportunity. And of course, with COVID and so forth, the push for collaboration and for international linkages is stronger than ever. And I think that COVID has suggested that we are all an I would say, connected space, and we all need to work together for better opportunities. So I'm going to share really some thoughts about how we should do impactful collaborative research and what are some of the challenges and maybe some of the lessons that we have learned as a team for the many years that we've been looking at this in Asia. I think the first thing that I need to really pose to everyone is why collaborative research? I mean, why can't we just do what we've been doing in the past? And also why Asia and why ASEAN? I'm pleased that the US Embassy, NEI has, revisited the emphasis on coming towards Asia and ASEAN, essentially. The first reason is that research, of course, is global. There's a pivot towards Asia, and that's a trend that people are recognizing. And I think that there's an opportunity for US as well as other countries to recognize this aspect. The second is that we need solutions for specific problems, particularly in eye diseases that are common, that are relevant, that need solutions here. One very simple problem would be myopia, which I think there's been a very little emphasis for, particularly in Western societies in the past. And a lot of the solutions that we're looking at has been developed in Asia. Atropine eye drops is being one, the effects of outdoor activities, near work and so forth that's been done by a lot of the Asian collaborators is the other. So I think solutions that need Asian solutions suggest the need to really move outside of our countries for collaborative research. Another area that I think is important would be things like specific types of diseases like angle closure glaucoma, and China and other countries have done those kind of work that has allowed us to really give evidence for best practices that will find it very challenging in other countries. The third thing is that the disease patterns are changing in Asia, right? We know that there's aging population, and this shows you many countries, Thailand included, but many Asian countries in ASEAN region, Vietnam, Indonesia, Philippines, everyone is going through an aging population. And of course, the risk of blindness and other diseases are increasing essentially. And I think that we do need to really look at, can we have solutions that are important for us to address this? Obviously, disease patterns are changing, and studies such as this one shown here between Japan and Thailand suggest that, smartphone addiction, for example, is quite high in ASEAN countries, in Thailand, certainly in Singapore and other countries. So I think we need to be able to address some of the changing risk factors. Now, of course, we also know that disease patterns are changing in Asia. We are moving away from acute diseases, simple diseases, in one sense, like cataract, refractive errors, to chronic, complex diseases that need solutions, that needs research for us to be able to innovate. And finally, ASEAN is a very exciting place to be in. It is, it has many of the things that we want to invest in, because, it is really both economically as well as from population-wise, as well as the future trend suggests increasing investment in healthcare and the biomedical sector and in public health prevention. So I think, there is some sense for hopefully further collaborative opportunities. Now, what kind of lessons can I suggest? I think the first is to look at guidelines, policy papers. One of the things that we noticed was that there isn't such things in many countries, and therefore we started developing guidelines that allows us to look at specific practices that can help here. And then we can move on to more complex multi-center studies such as the GAMA collaboration, where we share group level data, and that includes many different countries looking at the genetics of AMD and PCV. The Asian Eye Epidemiology Consortium is another one whereby we looked at very important things that we really have questions but no answers for, and that has provided some thinking about GA, which, as many know, there are increasing amount of trials and treatments available. And then I think Michael spoke about the need for AI, and that involves more complex studies, individual level patient data sharing. Dan Miller, my colleague, will be sharing this later on his work on AI for papilledema, but I think this suggests that there's good collaborative opportunities. And then I think we can think about long-term collaborative projects. We started some Singapore epidemiological studies in the early 2000s, and then we had fellows that came by and they started doing studies in China, Indonesia, and that offers opportunities for collaboration whereby they could also look at different studies essentially. Now, what are some of the lessons? Some of the lessons are that you should share reward multiple first and last authors, because there's really no limit to what you can do if you do not care who gets the credit. And I think that's important for us. I think Asians sometimes, and some countries in particular, tend to feel that maybe they would like to do individual studies, but collaborative research has such further lay. The second is that, of course, we must address the needs and gaps. In the mid-2000s, we noticed that the AMD phenotype was quite different in Asia. And then that drove Novartis and Bayer towards performing specific clinical trials in Asia, and that then led to guidelines that allow us to be able to improve the care of patients there. So I think that's important for us to address those kind of gaps, essentially. What about challenges and opportunities? I think the first is that it needs a lot of alignment of multiple factors. So it's not something to just say, let's do it. The vision, a lot of people have it, but do we have the skills, the work, the people in Asia, the incentive, the resources, and so forth, essentially. I think there are few charities and international grant bodies, so it's quite difficult to do collaborative research still. You sometimes depend on industry. There are specific grants, and we hope that maybe US, NEI might think a little bit about some of those grants that allow us to be able to do that kind of collaborative projects, essentially. I think the opportunities will be fellowships. Fellowships does allow people to travel, to meet people, and to be able to interact. And I think some of the networking opportunities are important for collaborative research. We look forward to the day that we can all meet face-to-face, because that really enhances collaborative research. Finally, I thought a little bit of pearls for some of the younger audience. that's on this Zoom webinar to say that, it's important to develop that people skills. It's easy to find collaborators, but you do need to focus on delivering on your side of the agreement and being responsive. Beware of some of the cultural differences that sometimes hinders collaborative research. Prioritize collaborative work over your own. I think that's always an important principle that allows us to be able to, meet the demands of other people. And then, of course, mentorship in Asia, it's appreciated. And I think, from senior people from the US and other parts of the world will help drive collaborative research. So I think with that, I'd like to thank you. And hopefully one day there's a chance to be able to have face-to-face meeting, whether it's in Thailand or Singapore or the US. Thank you very much.
Okay, so thank you very much for all of the speaker and very useful information. So this is end of the session 3, and then we will move to session 4. So session 4 will be vision, health, research, and training opportunities. So please welcome the chair of the session, Dr. Ruben Lim from Philippines, and he currently a president of Asian Ophthalmic Society. And the co-chair is Dr. Ngam Khair Rungwaravet from Sirirat Hospital, Thailand.
Okay, so thank you for the introduction. Welcome to the 4th session of today's symposium. This is actually, it might be the last session, but it's actually the longest. So we have we have a lineup of 13 speakers for this session. So in the interest of time, let us start. Okay, the first speaker for this session is Dr. Paul Chan, who will be talking about the AAO opportunities for research and education. He is the current secretary of the for Global Alliances of the American Academy of Ophthalmology and then chair of the Department of Ophthalmology and Visual Sciences of the Illinois Eye and Ear Infirmary, University of Illinois at Chicago. So Dr. Paul Chan.
Great, thanks so much, Dr. Lim. Again, wonderful to be here. Again, thanks for having me. I know many of you for many years, and in working internationally for RLP program development. And really that's where my heart is. Today, what I'm going to talk to you, I'm going to wear my American Academy of Ophthalmology hat, where I serve as the Secretary for Global Alliances. And I think that what I'm going to focus mostly on is this theme that I think many of the speakers have already touched on already, which is collaboration. And I want to provide some overview about the infrastructure that the American Academy of Ophthalmology has, specifically for global alliances focused on education. And we're going to talk a little bit about a new initiative, which is Academic Global Ophthalmology, which I also think fits in very nicely with these initiatives that Dr. Prakash, Dr. Brinks, Dr. Paisan have mentioned around collaborative research. Just to give you an overview about the American Academy of Ophthalmology, yes, it's the American Academy, but about 25%, so about a quarter of the membership is international. So, here you can look at the number of members on this map. This is a little bit older. This is pre-COVID numbers, but about 32,000 total Academy members and 9,000 were international members. Now, we're looking at less than that, obviously, because of COVID. Nearly 200 international member volunteers that serve on Academy committees. So it's very important to understand that we value very much the international perspective. As much as this is an American Academy, we want to make this globally relevant. Here are some of the committees and programs that are specific to the Secretariat, the Global Alliances Secretariat. So here you have the Global Advisors Committee, the Regional Advisors Committee, the Global One Advisory Board, the Global Education and Outreach Committee, the International Meetings Committee, and again, I'm going to touch on at the end this task force on academic global ophthalmology. So what are these committees and what do they do? So the Global Advisors Committee, so Dr. Wong is actually on the Global Advisors Committee, and many of our partners in the ASEAN region. It guides the Academy's international programs and services. So this committee really guides us into what our membership needs and really puts things in action. So this is really the governing body around that. The Regional Advisors Committee, again, some of the folks in Singapore and also in Asia are part of this Advisors Committee, provides regional advice and guidance, facilitates relationships. And this is one of the things that I think is really important, the relationships that we have, the friendships that we have, and the collaborations that help us really improve science and vision health. The Global One Advisory Board. So for those of you, who are participating in Academy programs, I think this has become so much more relevant. So the One Network, so the online web-based platforms that we have access to, especially during COVID-19, really, that's how we learn, that's how we communicate. This is how we're doing, this seminar right now. And the Global One Advisory Board makes sure that the One Network is relevant to ophthalmologists worldwide, right? So global content. The Global Education and Outreach Committee, again, this is focused on education. It defines educational pathways for interested ophthalmologists, accelerates ophthalmic education in the developing world. And a lot of the focus of this committee is on LMICs. And Suzanne Gilbert, who's here today, is also on this committee. International meeting committees, this guides the Academy's participation in educational programs outside the U.S. Again, we get the good fortune of partnering with so many societies, and we'll make sure that we're providing high quality speakers in a balanced way. One of the things that's become very interesting, and this goes back to some of the things that the other speakers have mentioned. When you look at just the landscape and the ophthalmologists and the trainees who are going through sort of this pipeline now, like their training, so many are globally focused, right? They want to have international opportunities. So many researchers, young researchers, Pete Campbell, I mentioned Pete Campbell again, are really interested and have experience, expertise in doing international collaborative research. So there's a passion for this new generation of ophthalmologists and vision scientists coming up to be globally minded and be global citizens. And we're seeing this more and more. So one of the things that I got involved in early is starting to think about these things for the American Academy of Ophthalmology. So how do we provide global ophthalmology content for this next generation? And what are the potential challenges and opportunities that we face? So we know that there are a lot of different resources all around the world. So there's a disparity in resource that trainees have, different mentoring possibilities, and Dr. Wong mentioned that. So depending on where you are, you're going to have a different experience in terms of experience, depending on what you're interested in, and also access. Different practice patterns, obviously, ethical, cultural considerations, and of course, language is always an issue. So one of the things that we developed early on, this is almost about 10 years ago, is something called the Global Ophthalmology Guide. And what this is an open access resource for global ophthalmology. Now, it initially started as something that was more educational, and it's starting to grow and gain some traction to expand into different things. So for example, could it be a source for curriculum development? Could it be a source for collaboration opportunities for residents, trainees, and practicing ophthalmologists who are interested in international collaborations and activity? Another resource, this is something that was developed when Rich Abbott was the Secretary for Global Alliances. This is similar to what some of the other speakers mentioned before about just learning what's out there, right? So who's getting funded and so forth. This is specifically focused on trainees and what training opportunities that are out there, either clinical or even in research. And you can see here that it's had over 100,000 page views since the launch about 5 years ago. Obviously, times have changed during COVID, but this was getting a lot of activity, and it's a great resource for connecting, especially young people, with training possibilities for research and clinical activity. Ethics, this is something that's very dear to my heart, is the ethics of what we do globally. Again, the Academy has invested a lot of efforts in providing resources, and this is the Redmond Ethics Center, specifically here, ethics in research. But there's also an advisory opinion that focuses on global ophthalmology. And again, you can see here the different rules that we have also, but in research, innovation, and clinical practice, this is one of the things that it discusses regarding research practices internationally and collaborations in that sense. One of the things that I've found to be a lot of fun in my career and working with the Academy are the partnerships that we've made with the supranational societies. So a lot of strong collaborative work with the Pan American, with the SOE, MIACO, and of course for me, the Asia Pacific Academy of Ophthalmology. So we have many global partners and we've worked with all of you, but this is the strength of our community globally. Advocacy, this is something that we should never, to a certain extent, forget that we need to focus on. The Academy has strong programs in leadership development, and in the work that I've done in ROP, and many of you know, in order to get science and programs off the ground, we need to advocate for what we do. We have to show that vision health matters. We have to make not just the community aware, but governments aware. So, this is something that we should talk more about, but also never forget. So in summary, the American Academy of Ophthalmology is very much focused on international collaborations and partnerships to support education, training, and also research. What we have brewing now, we formed a task force on academic level ophthalmology, really to focus on this discussion that we're having now. So providing opportunities for trainees and members interested in international activities. So either clinical care, advocacy, in this case, research and education. What are the next steps? And I think that things will start to grow from these symposium that Dr. Prakash and the NEI are putting together. But are there mechanisms to collaborate more to funding new projects, different initiatives, training programs, and I think the Academy will very much have a part in that discussion, and we look forward to talking more about this. Thank you.
Thank you. Thank you very much, Dr. Paul Chan, for that very informative lecture. So let us move on to the next speaker of this session. The next speaker of this session will be talking about exploring ocular biomarkers of Alzheimer's disease in Asian populations. This will be delivered by Dr. La Ong Sri from the Sirija Hospital, Mahidol University, Bangkok, Thailand.
Thank you very much. Good morning and good evening to everyone. I'd like to thank the organizing committee for giving me the opportunity to share the research proposal for possible collaboration. This is about finding the way to diagnose Alzheimer's disease years before the symptoms occur. Although Alzheimer's disease is not an eye disease, but the pathogenesis of this disease can result in eye problems, and more importantly, it also involves in the pathogenesis of at least 2 common eye diseases, including age-related macular degeneration and glaucoma. Studying the ocular biomarkers of Alzheimer's would not only help improve the care and hopefully help prevent the devastating disease to develop, we can also apply the knowledge about the ocular biomarkers to other degenerative eye conditions. I'm going to start with the reasons for studying Alzheimer's disease and the cause of this condition, followed by current treatments. Then I'd like to share with you the ophthalmic findings in patients with Alzheimer's that have been published in the literatures. And finally, I would like to propose a collaborative research. So, why Alzheimer's? First of all, Alzheimer's disease is the most common form of dementia and may contribute to around 60 to 70% of cases of dementia. The data from WHO last year showed that worldwide, around 50 million people have dementia, and there are nearly 10 million new cases every year. In the US, between the year 2000 and 2018, deaths resulting from stroke, HIV, and heart disease decreased. whereas reported deaths from Alzheimer's increased 146%. So much of the research to date came from Caucasian population. It is necessary to involve other ethnic and racial groups to gain a comprehensive understanding of this disease, which will lead us to the development of therapies that work for all people. In Thailand, the data from Thai Gerontology Research and Development Institute estimated that in 2019, we had around 1.4 million people with dementia. The number was more than double within 3 years, which is alarming. At Sirat Hospital, each year we have patients with early onset Alzheimer's around 100 cases and late onset Alzheimer's 2,000 cases. And what causes Alzheimer's? The two proteins that are thought to be the cause of Alzheimer's are amyloid beta protein and tau protein. However, there are other modifiable risk factors for the development of Alzheimer's, such as diabetes, hypertension, obesity, physical inactivity, depression, smoking, and a low educational attainment. Normally, the neurons in our brain produce amyloid precursor protein, or APP, that functions as a regulator of synapse formation. APP is cleaved by several secretase enzymes, including the alpha secretase, beta secretase, and gamma secretase. This figure shows that alpha secretase enzyme is a good guy. When it cleaves amyloid precursor protein, it will not produce the amyloid plaque. On the other hand, beta and gamma secretase enzyme will generate neurotoxic amyloid beta fragments. And these fragments are sticky, and if accumulates in the brain, they will destroy the neurons by blocking the neuronal cells. The other culprit of Alzheimer's disease is tau protein, which is a microtubule stabilizer found in the neuron in central nervous system. In Alzheimer's, tau is abnormally hyperphosphorylated and aggregates in the form of fibrillary tangles within the brain cells, which eventually leads to neuronal death. This slide tells us that at present, there is a variety of approaches to help make the diagnosis of Alzheimer's disease. Blood tests and brain imaging will be performed to rule out other causes of dementia symptoms, such as tumor or vitamin deficiencies. The rest of the approaches help diagnose Alzheimer's, but the patient brain will already be destroyed by the time the symptoms appear. This slide shows the process of change for Alzheimer's disease. It is thought that the disease begins 20 years or more before symptoms arise. This 20 years is a golden period that researchers around the world are interested because the results of current treatment for symptomatic patients are disappointing. The treatment for Alzheimer's are divided into pharmacologic and non-pharmacologic treatment. At present, none of the medications can slow or stop the damage of neurons that cause Alzheimer's symptoms and death. Researchers believe that future treatments to slow or stop the progression of the disease and preserve brain function may be most effective when administered early in the disease continuum. Either at the mild cognitive impairment due to Alzheimer's or preclinical Alzheimer's phase. And this brings us to the research project that I'd like to propose today. Since the eye, especially the retina, is part of the brain, there have been series of studies trying to find ocular pathology in Alzheimer's in hope of diagnosing those preclinical population. The following slides will show examples of interesting findings from recent studies. This study was performed at Boston Medical Center. The researchers used vitreous samples from 80 patients who were scheduled for vitrectomy. They tested those samples for the level of amyloid beta and tau protein, and they found that low levels of these biomarker proteins were significantly associated with lower cognitive scores. Whether this correlation would take us to the final goal of detecting preclinical stage of the disease It requires more studies in a diverse group of patients and a broad spectrum of cognitive function. This review was published in October last year and has given us information on recent findings and current knowledge regarding the application of retinal biomarkers in dementia assessment. Since 1986, optic nerve degeneration was with the reduction in the number of ganglion cells and in the thickness of nerve fiber layer was reported in post-mortem examination of human Alzheimer's disease eyes. But at that time, there was no study on the amyloid deposits. In 2017, and there was a study evaluated the amyloid beta plaques in the retina by scanning laser ophthalmoscope using the property of curcumin, which binds with the high affinity to the plaque in the Alzheimer's disease patient. In this study, oral curcumin was administered for a few days before taking the retinal images. The study demonstrated retinal curcumin spots in Alzheimer's patients in contrast to minimal spots in a healthy control and a non-Alzheimer's disease dementia. The author also noted that the amyloid deposits were found in association with blood vessels, which may explain the well-documented vascular narrowing and reduced blood flow in the retina in Alzheimer's patient. This figure F is the OCT image showing curcumin positive deposit above the RPE layer. So over the years, there have been many studies trying to find reliable, non-invasive, and inexpensive ocular biomarkers for Alzheimer's disease, especially at preclinical stage. The cornea, aqueous humor, lens, pupillary size, retinal blood flow, retinal thickness, retinal fluorescence, retinal amyloid beta accumulation, corridor thickness, and optic nerve head changes have been explored. The bottom line is we need to perform those studies in a larger number of patients and a diverse group of patients. So I hope that this a few minutes presentation might interest the team and we'll come up with a collaborative research in the near future. Thank you for your attention.
Thank you. Thank you very much, Dr. Laongsri, for your research proposal on the search for the ocular biomarkers of Alzheimer's disease in the Asian population. For the next speaker, we have Dr. Surakamet from the Department of Medical Sciences of the Ministry of Public Health of Thailand. The presentation will be on Thailand Genomics Project.
Good morning and good evening, everyone. My name is Surakamet Mahasri Mongkon. I am currently the Director of the Genomic Medicine and Institutional Support at the Department of Medical Science, Ministry of Public Health. And I was in the 2016 meeting with Professor Francis Collin that was held in Thailand. And I will present to you about Genomics Thailand plan that is already implemented in Thailand. My background is the internal medicine, and I graduated genetic epidemiology at the Cardiff University and received my PhD at the University of Tokyo. The Genomics Thailand is the national cooperative plan, and it is the plan that included around 17 organizations across 3 ministries. The main 2 ministries that contribute to this plan is the Ministry of Public Health and the Ministry of Science and Technology and Innovation, Ministry of Higher Education, Science and Technology, and Ministry of Industry. And I would begin with introduce you to the Ministry of Public Health and the Department of Medical Service, who is the host of this events in Thailand site is in the Municipal Public Health, and my department is Department of Medical Science. And this picture is the bird eye view picture of the Municipal Public Health. In the middle, you can see the football field, and that is the reference. And we have around we have 9 departments, and my department is responsible for laboratory service across the Municipal Public Health and also in Thailand. And we have the permanent secretary office that administrating around 800 hospitals across Thailand. And we work together to improve the health of Thai people. And the Municipal Public Health established the public health system, which includes the district hospital, health center, and it was covering around 70% of health service in Thailand. And this is the distribution of the health center, district hospital, and the secondary and tertiary hospitals. Ophthalmologists is usually work at the secondary and the tertiary hospitals. And we have the payment scheme that cover around 99% of Thai population. This is universal health coverage scheme. And these schemes pay for almost every service of health, like screening, screening, diagnosis, treatment, and rehabilitations. One of the service that has already implemented is the pharmacogenomics, and one of the first reimbursable service is testing of HIV 1502 for prevention of commercial-induced Stevenson and toxic epidermolysis in Thailand. And it is usually show up in the newspaper that Stevenson syndrome and 10 is causing blindness in Thai people, and this is the news around 20 years ago, 10 years ago, and she was blind because of the antibiotics induced Stevenson and 10, and the government paid for her compensation of the SJSN causing from this drug. The HIV 1502 is very common in Southeast Asians, and in Thai population we have around 8%, and in Indonesian is around 22%. This is virtually absent in Japan and United States. So we developed the test kit for detection of this allele, and it was the low-cost kit that can be implemented across the country. And within 14 years, we did the research, health economic study, changing the guideline, and did the pilot study. Eventually, we get the test reimbursable in 2018. And that is the input of this plan. We would like to introduce as much genetic testing service as possible to improve the health of Thai people. And based on that, the pharmacogenomics implementation, the number of SCS10 cases in Thailand reduced from around 15,000 a year to around 500 in 2018, and this year is around 300 cases. So that is the very good implementation of genetic testing across the nation. The plan itself began in 2016 when Professor Francis Conlin and Dr. Glass visited Thailand, and I was in that first meeting. And we moved on, and we did several memorandum of agreement across the ministry, organization, and we put this into the cabinet approval of the plan on 26th of 2019. And the plan is introduced to Thailand to try to use the genomic information across all age groups. We use it in reproductive health, neonatal screening, infectious disease sequencing, cancer testing, and non-communicable disease and in wellness. The plan itself is envision that Thailand will be leaders in this field within the next 5 years. And we have 2 pillars. This is the research pillar and the service pillar, and the 4 underlying strategy supporting these 2 pillars. And within this year, we will start 50,000 whole genome sequencing projects that we will sequence non-communicable disease and rare disease. So all ophthalmic disease is the target for this whole genome sequencing for identification of new positive genes in Thai population. And we will establish the National Genome Data Bank and the National Bioresource Center doing the DNA extraction and collecting of DNA sample. And the 5 area of research includes the cancer, rare disease, pharmacogenomics, and infectious disease, and the aging. And we aim to develop new guidelines, health clinic evaluation, and introduce the genetic testing service into the health system. This year, we will evaluating the familial cancer screenings and the targeted therapy, whole genome sequencing of bacteria, COVID-19, pharmacogenomics testing, and the next few years we will try to implement the national program for newborn screening. And this aims to include into the health care system. So we are really focusing on the primary care team, and we are looking at how to interfacing this whole genome sequencing projects with every organization that would like to use the whole genome sequencing, and we are also open for collaboration with international organizations. So that's all for me. Thank you very much.
Thank you. Thank you very much, Dr. Surakamet, for presenting your very impressive work with the Thailand Genomics Project. So we'll proceed to the next speaker. The next speaker is Dr. Dan Milea from the Singapore National Eye Center. He'll be talking about collaboration research on development of AI for detecting papilledema.
Hello, everyone. Thank you very much for this opportunity to talk at the symposium. I would like to thank Dr. Paisan and the organizers. It's a high honor for me. I'm a neuro-ophthalmologist and a visual neuroscientist working at the Singapore National Eye Center. And as a Frenchman who lived in Singapore for more than 8 years now, I think I'm a very good example to show that borders have no meaning when it comes to close collaborations between people and researchers who are very passionate about putting together efforts and resources. Singapore has been a wonderful place for me, welcoming and serving also a great platform connecting with other Asian countries and my collaborators from the US. Those are my disclosures, my grants. And as a neuro-ophthalmologist.
Sir Dan, can you share your screen? Are you?
Yeah. Do you hear me?
Yes, we can hear you, we can see you. You don't see your slides.
Oh, I'm sorry. So I was just showing my disclosures. And as a neuro-ophthalmologist, I was saying that my main interest and mission is to reconnect the eyes with the brain. And for this particular presentation, I'll use the artificial intelligence approach, although many others more brilliant than I spoke before me about this. But one critical question in ophthalmology is if an optic nerve is swollen. In this case, it may not be easy to detect optic nerve swelling, which is due to papilledema and raised intracranial pressure. the eye is still a wonderful window to explore the brain, and papilledema detection is absolutely critical. Yet one of the problems is that there are not enough neuro-ophthalmologists in the world to look carefully at papilledema. And non-ophthalmologists, mainly neurologists, are not experts at this. So our next question was, could we use AI to identify abnormal discs? The question was very interesting, but there's not enough data. Papilledema, after all, remains a rare condition, and we know how data hungry is artificial intelligence. And this came into a context where we were going to Bangkok 2 years ago at the APAO. I know that most of the people in the audience were there. And the neuro-ophthalmic community is very strong in ASEAN and also in the United States. You probably see Dr. Miller in the middle, Tony Arnold, Dean Sestari, and many others. And all of our main players in ASEAN who were there. And we thought, why not leveraging on this incredible relationship and creating a consortium which was called Bonsai like brain and optic nerve study with artificial intelligence. And we encountered an incredible enthusiasm. Many countries came together. Now we have more than 30,000 images. We have probably more than 20 countries now. The updated slides in more than 20 countries, and many of them are in ASEAN, United States as well. And these are the Bonsai Consortium collaborators, and I was highlighting in red the ones in ASEAN countries and in the United States, many of them. And the result of this big effort was a paper that we did with Tianyin Wang, with Daniel Ting, with my close collaborator Raymond Najar, and many others, in particular with very gifted engineers in Singapore. As you probably know, Singapore is a very hot hub for artificial intelligence. And we published this paper the New England Journal of Medicine a couple of months ago. I will not go into the data, it's not very important, except of the fact that we had a training.
Dan, excuse me, I'm sorry. Are you showing your slides now? Because we couldn't see your slides.
Oh yeah, absolutely.
You are? Are you sharing?
Oh yeah.
We couldn't see it.
What
we can hear you very well, but we couldn't see the slides.
Well, the images would be better.
Can you share a screen? Have you shared?
I did. Yeah, I'm sorry. Let me try again. Do you see it now?
Yep. Perfect.
Okay. I apologize. So I'll go
see the
quickly.
bonsai now.
Right. So quickly, papilledema revealing brain tumors, and this is absolutely critical for non-ophthalmologists. Our question, if we could identify papilledema with AI, and this is the group of very vibrant neuro-ophthalmologists in ASEAN meeting in Bangkok. Many of them you know and are among the audience. And we created Bonsai, this artificial intelligence consortium looking specifically at papilledema. And those are all the countries that are now on board. A couple of details in red, that ASEAN countries and US centers. And this is the paper we published in New England Journal of Medicine, so I caught up. Those are the results, are not very important, except that we had the chance to have the most important and referenced neuro-ophthalmologists in the world. And these are a couple of results that are not very important, except that showing the number of countries. You heard Dr. Michael Chang talking how important it is to have a generalizable results. We looked at a multi-ethnic population, very diverse, using several cameras, and we validated us in a couple of countries. And I will just mention, because of this, Thailand and the US, and I will just show rapidly our wonderful collaborators in Thailand, Dr. Kevin, Dr. Tanya Tut, Dr. Yanin, and many others who just shared this slide with you, saying that we are very honored to be part of this powerful collaboration between Singapore, Thailand, and many countries in the world. So I will probably stop there, saying that we have a next step, and there's ongoing work with all those countries, with Thailand and with other ASEAN countries. We want to move from code to clinic, showing that these algorithms can be applied in everyday clinics. Thank you very much.
I think everybody can see all that. So yes, I'll be talking about our Staccato trial and just a little brief bio about us. And I really can't say anything about myself without also talking about my colleagues and friends. So I have their bios here as well. But yes, I'm John Gonzalez. I'm associate professor at the Proctor Foundation at the University of California, San Francisco. I'm the director of the two uveitis fellowship programs here. So both the domestic AUPO fellowship program, as well as an international program known as the Vaughan International Fellowship. And so we train an ophthalmologist that is interested in conducting uveitis research, as well as getting additional uveitis training from international countries. And actually, very recently, many of our trainees in that particular program have been from Thailand. Currently, I am supported by an NIH NEI K23 mentor grant that is studying keratoconjunctivitis sicca and Sjogren's syndrome. I previously was a diversity supplement recipient from NEI, and actually my support from NEI extends even before then. As a medical student, I was a Howard Hughes and NIH research fellow. And then we are gearing, I just recently submitted a UG1 EPI grant through NEI for continued studies relating to Sjogren's syndrome, microbiome and ocular surface microbiome in Sjogren's syndrome. And then my colleague, Thanapong Somkij, he is chief of the uveitis unit and chief of the retina unit at Chulalongkorn University. He is a site investigator for the current trial that I'm talking about, and he is also founder of a collaborative meeting that we have biannually between Chulalongkorn University, Khon Kaen University, Proctor, as well as the broader UCSF Department of Ophthalmology community. My other colleague and friend, Wipara Laurviro Janakul, is faculty staff of the vitreoretina and uveitis units at Khon Kaen University, also a site investigator for Staccato at her institution, and then also a co-founder for the Chulalongkorn, Khon Kaen, Proctor, and UCSF biannual meetings. I just want to read briefly the mission statement for the Proctor Foundation, which I think aligns really well with the goals of the National Eye Institute. The Proctor Foundation was established in 1947, and it's a campus-wide organized research unit at the University of California dedicated to research and training in infectious diseases, infectious and inflammatory ocular diseases, and the application of this research to the prevention of blindness worldwide. And so that mission statement has not changed, and that mission statement comes from 1947. A little bit of background about cytomegalovirus in the eye. As we all know, CMV is part of the herpes viridae family. And just like the other viruses, has been associated with ocular inflammation. So certainly the case for HSV, VZV, and even EBV, but CMV as well can be associated with ocular inflammation. And so the seroprevalence varies in different countries. It seems to be higher in East Asian countries compared to Western countries, but anywhere from 60 to over 90% of a population by the time we're in our 60s to 80s years of age are positive for CMV, and often we acquire it just from relatively innocuous activities, like a kiss from when we were young from a relative. Certainly can be associated with devastating congenital infections, including developmental malformations and intellectual disability. And then I think we're all familiar with disease caused in immunocompromised individuals, including retinitis. And so I think we're all familiar with some of the devastating complications in the eye with respect to CMV and HIV and AIDS patients. But to be quite frank, it's been a long time since I've seen this kind of presentation, since we have such great control, at least in the US, with respect to HIV and AIDS. More often we'll see it perhaps in patients with diabetes or who are on iatrogenic immunosuppression. We'll see CMV retinitis, but it has a little bit of a different presentation, I feel, than the classic HIV AIDS patient with low CD4 count. But CMV can also cause inflammation in patients that are immunocompetent with respect to the anterior segment specifically. And so we've been becoming increasingly aware that this is implicated in a variety of idiopathic anterior uveitis. In particular, like I noted, immunocompetent patients And also it comes in a couple of different flavors. Fuchs heterochromic iridocyclitis or the Posner-Schlossman syndrome. Those are two well-known syndromes, but also sometimes has non-specific anterior chamber inflammation. Some of the complications for CMV anterior uveitis in particular include pain and decreased vision during flares, but also the development of cataract, glaucoma with subsequent vision loss, and then corneal failure with subsequent vision loss. One of the greats in this particular field, Soonfik Chi from Singapore, has noted that in particular, patients that fit the phenotype of either Posner-Schlossman or those with Fuchs heterochromic iridocyclitis, many of these patients are found to actually have CMV on anterior chamber paracentesis. And these patients do very well in terms of the control of their inflammation, improvement of their intraocular pressure with either intravenous or oral ganciclovir, but often patients will recur when their medication is stopped. So there are a variety of overlapping clinical findings with respect to CMV anterior uveitis, with respect to HSV and VZV, for example. And distinguishing CMV from HSV and VZV is important because the treatment is quite different with respect to CMV versus HSV and VZV. So valganciclovir certainly manages all three of these viruses, but it comes with some toxicity to the body. And so we typically reserve valganciclovir for our patients that are PCR positive from the aqueous. So I'm just going to kind of go through these medications. One thing I'll mention is that there has been a lot of interest in using topical ganciclovir. And so what we have noticed is that our colleagues in East Asia, in particular in Thailand and Taiwan, more frequently will use topical ganciclovir 2% for the management of active inflammation associated with CMV anterior uveitis, as well as for long-term antiviral prophylaxis. But there haven't ever been any head-to-head comparison studies using these two modes of therapy. And typically when we look at a lot of these studies, the treatment outcomes typically are clinical. That means assessing intraocular inflammation, such as anterior chamber cell grade or flare grade, or looking at intraocular pressure as sort of surrogate markers for viral load. So there are a lot of unknowns that we've been dealing with respect to CMV anterior uveitis, and that includes what medications are associated with the best viral load reduction, also looking at the concept of long-term antiviral prophylaxis. What are the recurrence rates when patients are on or off long-term antiviral prophylaxis? And then also what mediates recurrences? Is every single recurrence of inflammation mediated by active viral replication, or is there some other process at play that may be modulating the host immune response, even in cases where there are active flare-ups, at least that we detect clinically? And then additionally, we don't know much about host genomic or transcriptomic signatures or viral mutations that might be associated with susceptibility or recurrence. So here's a photo this is actually back in 2017. This is the first meeting of Staccato at Chulalongkorn University. And so we had met with Dr. Thanapong and Dr. Wipada, and we were not known as Staccato back then, but we started talking about these issues with respect to CMV anterior uveitis. And you can see on the upper right that we started to write some ideas down for this particular trial, this project, and then you can see that the meeting extended a couple hours longer, and we had a lot more ideas in terms of looking at primary and secondary outcomes, and then also what markers we were going to use to assess for improvement or response to therapy, especially with respect to active CMV anterior uveitis. And from that meeting, ultimately, Staccato was born, systemic and topical antiviral control of cytomegalovirus anterior uveitis treatment outcomes. And so this is a collaborative project. It is funded right now by the Huang Pacific Foundation. Right now, this is a pilot project, and we're actively enrolling. And this is a collaborative project between Chulalongkorn University, Konkan University, and then the Proctor Foundation at UCSF. And right now, for the pilot trial, what happens is patients that are suspected of having anterior uveitis related to a viral cause will receive an anterior chamber paracentesis, which now at most of our centers is standard of care. The fluid is split into two parts, And if the patient ends up being CMV positive, when they return for their results the following week, they can be randomized into the trial into one of three arms: oral valganciclovir, topical ganciclovir 2%, or placebo. Participants then return a week later where they receive another anterior chamber paracentesis. And so now they've been on treatment for 1 week. And then the patients continue on for another 2 weeks, and then the trial is complete. Our primary outcome, which I have here circled in green there, which shows PCR being performed at Stanford. So our primary outcome actually is a microbiologic outcome. And so this is something I think that is notable about this particular study, is that we do not have a clinical outcome in terms of looking for time to achieve clinical quiescence, but rather it's a microbiologic outcome looking at viral load. So we're looking at the viral load difference between pre-treatment and then post-treatment for a week. Secondary outcomes include assessing the proportion of patients that achieve clinical quiescence at the end of the study. And then we're also following things like intraocular pressure. And the goal is for this study to provide preliminary data that will ultimately go on to for an application for NIH-funded RCT, which I'll get to in just a second. And so to date, we have enrolled almost 24% of our entire group that we need to enroll. The goal is 99 participants with 33 participants per arm. Actually, right before this meeting started, I was just enrolling a participant at the Proctor Foundation. And so we had specified that we were going to do an interim analysis when we achieved around 12 participants. We are all still masked to the outcomes with respect to treatment arm, but you can see here that most importantly, there is good correlation between pre and post-treatment values. So this is very important. And so now actually we are gearing up for an application to the NIH for a UG1 grant. And that actually comes due in May. So we're actively working on that. And this grant will be 2 phases for the project: the acute active inflammation phase, again, a microbiologic outcome, and then long-term antiviral prophylaxis. And here again, we have another microbiologic outcome. So when patients are being followed, and if they exhibit a recurrence, they will receive an anterior chamber paracentesis so we can understand better whether or not these recurrences are mediated by viral replication. Additionally, our lab is able to do metagenomic deep sequencing so we can identify mutations associated with antiviral resistance. And so with that, I would like to thank everyone, and especially my colleagues, and I hope we all get to meet again soon in Thailand. Thank you.
Thank you. Thank you, Dr. John Gonzalez. Okay, that's a wonderful name for a study, Staccato. Okay, so we're almost halfway. Okay, there's also one more speaker. There are 2 more speakers prior to the break. Okay, so the next speaker is on applications of artificial intelligence in ROP, to be presented by Dr. Pete Campbell and Dr. Achara from the KCI Institute, Oregon Health and Science University, and the Rajaviti Hospital, Bangkok, Thailand. Dr. Campbell.
Thank you. I think my colleague and friend, Dr. Wah, is going to start the presentation.
Okay, thank you for having me today. So I would like to talk about the situation of RP in Southeast Asia and even in Thailand. So I have no financial disclosure. So you know that the main cause of childhood blindness is the RP in some middle country and then in some city in Asia. So when you look at the map of the Southeast Asia, you can see that it very vary from the red one with very high risk and the green one and the black one that have not well educated from the neonatals. So the most problem is about the overload of the babies and the shortage of the nurse and the work team. So summary of the RP healthcare in Southeast Asia is about we need to train well nurse, even pediatric ophthalmologists, anesthesiologists, low vision therapists, and even some optometrists, and even some equipment is very important. We do have more in some country, laser to treatment, telemedicine system to build, and the vitrectomy even in the surgery cases. And pediatric ophthalmologists and pediatric retina also important to require for ROP experience as well. When we look at the data for RP screening in Asia, it's very, very different, even in Thailand, from our neighbor, Philippines, Indonesia, Vietnam, and Singapore is very different. So even in Thailand as well, it is the most northern part of Thailand. The screening criteria is very different from every province, and the valley from lower part of Thailand, even in Bangkok, is also different from screening. The incidence of the RP in Asia, we do have more higher birth weight and later GA than reported from the Western. So when you compare the incidence of the RP in the past, from Thailand, it's about 10% in APRP and about 30% from any state, compare between our neighbor in Southeast Asia. And the problem that when you look at the map, some countries have shortage of pediatric ophthalmologists, pediatric retina, and even the expert RP for screening and treatment RP patients. And about the surgery, so the surgery RP in Southeast Asia, sometimes we need to refer between Asia and Thailand neighbor. And some countries like Singapore, Japan is very cost expensive. That is to, and this is the data from the RP incident in my hospital, Queen's National Institute of Child Health. So in the last 2012, it's about 37%, and also getting decreased right now. Even you can see the stage 4 and stage 5 is still getting less until right now, and then the total number from 2012 is 200 and getting less until now 2012. So thank you for your attention, and this is my friends around Southeast Asia from the data. And I think that this is the good beginning of the good cooperation that in the future we can have more data about RP more. Thank you for your attention.
Thanks, Wa. My name is Pete Campbell. I'm gonna talk a little bit about some of the work that our team does, really trying to expand work we've done on artificial intelligence in the North American population into where it's really needed most, where the disease is more prevalent and where there are fewer ophthalmologists, as Dr. Wah mentioned. I'm Associate Professor at OHSU. I'm a member of the ICROP committee, and I'm on the AAO committee for artificial intelligence, and I'm an adult and pediatric retinal specialist. Work with a great team. You've heard from several of them today, Mike Chang and Paul Chan, who really, the work that we're doing now is really based on their brilliance and thinking about where this field needed to go 10 years ago. So we've heard a lot about AI and the potential. And Mike mentioned the work that we did a few years ago demonstrating that AI can diagnose plus disease in images, which was fascinating at the time, but it's sort of a solved problem at this point in the sense that we know basically if you have enough data, AI can learn to recognize images. And the real question becomes, why is that useful, or how could that be useful, and how does that lead to fewer blind babies? Dr. Dan earlier mentioned, from the idea of from code to clinic, there are far more papers being published right now than patients being helped with artificial intelligence. And so our goal is really to move this to where it's useful. Dr. Chang mentioned moving the diagnosis from being qualitative to being quantitative, and the work that we've done has really demonstrated that using a single photograph of the posterior pole, you can measure vascular severity in ROP in a way that corresponds to zone, stage, plus an extent of disease, including APROP, which is highly prevalent in low and middle income.
Pete, excuse me, Pete. Are you moving your slides? Couldn't see.
Yeah.
You're still. We can only see the first page, the title page, title slide. Can you put it on full screen?
Yeah.
There you go. And full screen. Yeah. Now it's not on the.
Can you see this now?
Yes. Potential applications. Yes.
Perfect. I'll just leave it.
Can you do it on full screen?
Well, that's what I tried to do.
Slideshow. Well, this is fine, but it'd be better if you're on slideshow.
How's that?
Previous one would be better. Okay, I think let's just stick with the previous one.
Stick with what's working. All right, I'm just.
I think this would be fine. This is fine.
All right. So
our real question was, can we translate this work that we're doing into regions of the world where the disease is more prevalent and there are fewer ophthalmologists? And if you think about screening for secondary prevention, there's a huge population at risk, especially in regions where bigger babies are getting ROP. And so the question is, can we reduce screening burden for ophthalmologists without missing cases of severe ROP? And so very much in the spirit of this meeting, this is work we just published in a collaboration with the Aravind Eye Hospital in India, where we essentially retrospectively looked at a population-based cohort of Indian babies in an ROP telemedicine program that was set up with funding from USAID and has ongoing funding from USAID and the SIVA Foundation. And basically found that in a real-world population, the artificial intelligence algorithm works to screen for clinically significant ROP with very high sensitivity and specificity. And so this is sort of the first proof of principle that developing a system of care and using AI may be effective. The other part that was interesting is we had the opportunity to look at multiple NICUs. Dr. Wah mentioned that NICUs are of variable quality in different regions, and oxygen titration can be an issue. This is a scatter plot of babies in the Indian ROP telemedicine program based on gestational age and birth weight. And the babies in the red shaded area are babies who would not have met US screening criteria. When we compared NICUs in that telemedicine program who had oxygen blenders and pulse oximetry compared to those who didn't, we found, using a quantitative AI method, less ROP in the better resourced neonatal care units. And the difference was most notable in bigger babies. And so this really gets into the issue of primary prevention of ROP, which is a big issue. This was one baby who was a 34-weeker who wouldn't have been screened and been at zero risk of ROP in another setting, who developed aggressive posterior ROP. The reason this is relevant is that if we could improve primary prevention, that would have a larger impact on blindness prevention than any new technology or OCT or anything else that we can develop or that the NEI can fund. Because it would greatly reduce the population at risk and therefore greatly reduce the number of babies going blind and greatly reduce the number of screening exams needed for ophthalmologists. But the fundamental point, if you remember one thing from what I'm going to say, it's that last point, which is that all of these ideas are theoretical and they really need to be implemented. And so we just wrote a review on moving from concept to implementation, which is going to be coming out soon. And it really does fall in the sphere of implementation science, which I think is where the NEI and NIH really need to move to sort of move. I've always said that the lowest hanging fruit for blindness prevention is implementation of existing knowledge. And so our goal is to take this technology from the theoretical and from the paper to really implement it into practice. And the work that we're doing, this is just sort of one step along that way. So thanks so much for the opportunity to be here.
Okay, thank you. Thank you, Pete, for your presentation. Okay, for the last presentation prior to the break, okay, is another topic on the ROP, but here is Dr. Pearl Tameses Vidalon from the Philippine Academy of Ophthalmology will be presenting the challenges of an archipelago ROP in the Philippines. You can try clicking on the lower left-hand corner. You can see the previous. There.
Yeah, all right. So, I called, the title of this presentation is The Challenges of an Archipelago, ROP in the Philippines. Well, let me just tell you a few things about this our country. It has so many islands, big and small, 7,100 islands, and divided into three large groups: Luzon in the north, the Visayas, composed of many, many islands, and Mindanao in the south. It has 13 administrative regions for easier government, and it has 4 special administrative regions. Now, NCR or Manila, that area in Manila, Metro Manila, is one administrative region, and there are 2 in the south in Mindanao, 2 administrative regions. These are the regions that have large Muslim population. Okay, so, and then I think I went through that. Okay, now, the total number of ophthalmologists is about 1,700, and many of them are in Metro Manila. And like the previous speaker said, there are places in the world where there are not enough ophthalmologists, doctors in the provinces, in the rural areas. And since we're talking about ROP, let me just share with you that the total that we have is 86 from the Vitreoretinal Society of the Philippines, which is 52, and approximately 34 from the Pedia Ophthalmologist Group. And the country now has a population of 110 million, with birth rate of 15.6 per 1,000, premature birth rate in 2017 of 13%. And I was told that the number of level 2 and 3 hospitals are about 309. All of them should have NICUs, but from experience, I don't think so. Many of them do not, level 2. And the number of private hospitals is about 1,000. And perhaps maybe 2/3 of them, only 2/3 of NICUs and neonatologists. Next. I went through that. All right. The ROP working group started as an advocacy in 2012 after a fateful meeting in care of Orbis in Guangzhou with Drs. Chang, Mike Chang, and Paul Chan, and Tom Lee. And it also came about because of many increasing numbers of blind ROP blind babies and few referrals. So we formed this ROP working group with a Silip Bulilit master plan. Silip is to peep, Bulilit is a little child. Our goal was to decrease prevalence of visual impairment due to ROP. Now, we have 6 concerns. We'll go over them one by one. And here we are. ROP screening criteria based on Philippine data is one of our concerns. And to address that, we did some studies. There was an inter-observer reliability study among ROP expert screeners. And we also proposed new ROP screening criteria because that was a time when many countries in Latin America, South America, and Asia had changed their screening criteria. And we did too. We found babies that were bigger and older, premature babies. But this was not well received by the pediatricians and the neonatologists. So came about a prospective ROP study, which isn't done yet. Unfortunately, in 2018 or 2019, I think, a study was made between the 2005 guidelines, which was basically US guidelines, and 2013, the one that we recommended. It was a comparison. And lo and behold, people were satisfied, and we arrived at a consensus signing with neonatologists and pediatricians. They were quite happy about this. So that's task number 1 done. Now, second concern was awareness among lay and medical community. For the lay, we did lay fora, we did a media blitz, during which we discovered that testimonies from adult and adolescent ROP patients was a very strong tool, very good tool to get patients to listen to you, parents of patients. Now, we went to social media. We were so happy to discover that there were Facebook accounts of parents of ROP babies, and we are now working with them. The Academy provided us a hotlines for referrals. Now, for pediatricians, we take every opportunity to lecture to them wherever, during their meetings, in small groups, using a uniform slide deck developed by the working group. We gave posters so that they could hang this everywhere in the hospital, including the NICUs and the clinics. And now, for general ophthalmologists, we went on, we did symposia and lectures and hands-on sessions with dummy babies, dolls, using a wide range of gadgets from I/O to smartphones and the retinal cameras during the mid-year and annual meetings and whenever we could during Sight Saving Month, World Prematurity Day. There were also posters for the hospitals and hotline for referral. Now, awareness among eye doctors is a little more of a higher level, so we went after the residents. Why? Because the residents, when they finish their training, they could go back to, when they go back to the provinces, they could be screeners. We'll talk about that later, but awareness of residents came, was the same for GOs with the symposia and the sessions. We went into a web-based training module. We have to thank Paul Chan for this. Most of the 31 training programs in ophthalmology in the country joined this web-based training module, which by the way had exams, and they knew what they missed out on. We had to learn more. And we required them to give us training, ROP training and incident surveys to track their progress. All right, we also plan to go into mentoring activities with our OPWG members for the general ophthalmologists, but COVID came. So we weren't able to do that, but we plan to go ahead in June, virtual. Okay, lack of RP screeners. Like I said, we're targeting the residents because they're the ones who are going back to the provinces, hopefully, if they don't get stuck or enjoy Manila life or metropolitan city life. They can go back and bring their skill and be able to help with screening. Again, the web-based training module was very helpful, and the survey. And we conduct training sessions for RP screening. I'm quite repetitive here, but I have to say this again. The symposium, the lectures in the hands-on section, the mentoring program, and partnership with private individuals and foundations. This is Apple, the app. He has been helping us quite a bit. Back into the Apple, the App International Foundation project is also the Knights Templar Eye Foundation and Western Union. Okay. The next is to establish a referral network system. We have a list from the VRSP, the Retina Society, and the Pediatric Ophthalmology Society, list of screeners. We match these doctors and with the hospitals that with NICUs and neonatologists and the nearest laser and retina surgery facilities. Again, there's a hotline that can be called, and we're now going to more complicated things. There will be gaps with the networking. There will certainly be areas where there is no NICU, no neonatologist, no screener. So we plan to go into ophthalmology soon, establish reading centers. As far as funding and treatment are concerned, we've been helping PhilHealth, which is like Medicare, the government insurance. It also already has a Z package for prematures, but they have to do something about the cost assigned to it. Not enough. You know that very tiny babies stay for months in the hospital, and they consume most of what is allotted by PhilHealth. Now, we're also helping with the helping DOH, and certainly private individuals have also helped us, like Apple. And for treatment, it's the same, PhilHealth, DOH, and private individuals. Now, what are our future projects? Networking. We are at networking right now, and we know that there will be gaps. And this will lead to ophthalmology. We're convinced of that. And if you go into teleophthalmology, we should set up reading centers, provide gadgets, fundus cameras, and the very nice attractive smartphone with adapter, and training for capture of images and training of personnel. We intend to go build a registry so that we have data, which we really don't right now. And when we have the data, we will be able to revisit. When we revisit and reevaluate our policies and guidelines, we have something to fall back on, we have data to look on. And what about government involvement? Yes, we have been helping PhilHealth with networking. Now, this is the most difficult, government legislation for mandatory screening, as in newborn screening, not premature, newborn screening, hearing screening, congenital anomaly screening. We want that to become a law, ROP screening, and that will, I think, is the highest mountain, highest hurdle for us. And one day that will happen with a group that is very gung-ho about what we're doing. Now, this is my last slide, just to show you our involvement with social media, because that is a very powerful tool. And many people come reach us through these numbers and through these sites to ask us questions, to ask for referrals to doctors and hospitals. I think this is my last slide, and I would like to say thank you very much for this opportunity to speak today. Thank you.
Thank you. Thank you very much, Dr. Pearl Tameses Villalon. Okay, so before we proceed to the last 6 speakers, we'll be taking a 5-minute break, okay, because again, it's quite a long session. Okay, so we'll resume in 5 minutes.
Hi. Good evening to everyone in the East, and good evening to all in the West, and good morning to all in the East. And good morning to Dr. Lim, the President of the AOS, the Chairman of this session. I'm Dr. Ngam Khaireng Waravet, Chairman of Department of Ophthalmology, Faculty of Medicine, Silat Hospital, Thailand. I'm the co-chair for this session. So the next presentation will be role of NGO in research, capacity building, and a case study in Cambodia. This will be presented by Dr. Gilbert. Dr. Gilbert, please.
Thank you very much. Thank you, everyone. This is just delightful to be with you today for the program, truly a visionary program. I've participated in quite a few conferences over the years. As you see, I've been involved in global eye care for over 40 years. I also serve as North America Region Chair of one of our co-sponsors of this meeting, the International Agency for the Prevention of Blindness, as well as being president of the International Society of Epidemiological and Geographical Ophthalmology, which I'll talk about a bit later. So again, I'm just delighted to be invited and also to represent a lot of collaborative work that's been developed by and funded by SEVA Foundation, along with many of our partners, some of whom are on the program today. So as noted, I'm addressing the topic of the role of NGOs in research capacity building. We're talking about a lot of aspects of clinical research. We're talking about education. Dave Wilson gave some important inputs there, but we really haven't talked a lot about how we make sure that research is relevant and conducted by people who are as local as possible. And for the moment, I'm referring to research which is conducted as part of NGO program development. Non-governmental organizations are always known for providing services. However, rarely are non-governmental organizations associated with research. In the case of SEVA Foundation, we've been research-oriented from day one. I'll give a case example about early work we did in Nepal, literally 4 decades ago when I was really a young person. And then I'll describe our capacity building. I'll spell it correctly next time. And then I'll end with a case on several operations research projects in Cambodia and what's next in promoting operations research among NGOs, universities, and ministries of health worldwide. First, a glimpse of SEVA Foundation origins. SEVA Foundation really sprang from the World Health Organization successful smallpox eradication campaign. And what was so important here is that a number of the key drivers of that campaign went home and wanted to do something else useful and productive on the planet. And some of them who had been smallpox workers gathered together to start SEVA Foundation, along with a crew of interesting friends. We were very fortunate to have among our founders, Dr. Jeevan Kedaswamy, and from India, who was just starting Aravind Eye Hospital at that time, and Dr. Ramprasad Pokhrel from Nepal, who was just starting the Nepal Eye Hospital at that time. So when we talk about capacity building, we're really talking about developing the systems and the people to continue to provide services on an ongoing basis. First, we focus on service delivery. Of course, that's number one. But to provide services on an ongoing, continuous, sustainable basis, we need to have the means to train people locally also. So SEVA has devoted many decades to developing systems for training local ophthalmologists, optometrists, managers, community health workers, and now researchers. And that'll be the focus of our next few minutes together. So when SEVA started in 1978, we started by launching a program with the government of Nepal and World Health Organization, and we invested our first donations not in direct service delivery, but rather in conducting a national survey. And in fact, the Nepal Blindness Survey was the first national systematic survey of blindness conducted anywhere in the world, and its results were quite staggering. This was a time when the conventional wisdom was that most blindness was caused by trachoma, and we found, au contraire, we have a huge cataract problem. So suddenly what we were facing was a big surgical program rather than an infectious disease trachoma program in Nepal. Conducting the survey took a lot of effort, but there were a lot of unintended positive impacts. One of them was that the way we designed the survey, we employed a lot of people who really became some of the key workers in Nepal for offering services nationwide in the decades to come. Also, the survey created awareness of eye care needs and buy-in by the local powers that be who wanted to see eye care come to their community. We also were able to develop a cogent plan with WHO and the Nepal government, which attracted other international eye care NGOs to come and sponsor startup programs in different parts of the country. Long term, we see tremendous benefits, and this is a lot of what fuels SEVA's interest today in research capacity building. Nepali researchers from the Nepal Blindness Survey went on to become leading ophthalmologists, ophthalmic assistants, and managers in the country. We developed a baseline that's been used since then repeatedly for national surveys and program improvement. And as importantly, over time, operations research in Nepal is conducted by Nepalis, analyzed and reported by Nepalis, which is very important to us to have local authors, not only of articles, but of the ideas that ground the research itself. So over time, SEVA has looked at a number of ways to scale research, and we have had a number of processes over time to work with partners to identify topics that are important to them in their locale, to create local teams to conduct the research, build the skills, there's a whole big story there, train people in research skills. We work together to garner research funding, or SEVA has self-funded. We also conduct the research, and then we promote a lot of cross-learning across SEVA partners who are engaged in research projects and can support each other along a very difficult arc. These are some examples of SEVA-sponsored studies by partners over time. You'll see they range a lot of geographies. They're all very practical, and they have the benefit, again, of addressing questions that are being asked by the local eye care teams. You don't have to be a PhD to do this work. You don't have to have a master's in public health or statistics, though I will say it does help. After many years of doing this work, SEVA did an assessment, and back when we could have meetings face-to-face, we were at ARVO, my colleague Ken Bassett and I presented on building research capacity through global partnerships, very much like the theme of this conference now. But what we deduced from our conversations with many partners and a survey was we determined we needed a long-term investment to build research skills, not only of an individual researcher, but of their research unit and building collaboration across units. That was the only way we have determined that you can embed research as a process inside programs where local staff frame the questions, conduct the studies, and utilize the findings. So today, SEVA is involved in a lot of research and learning projects spanning many different disciplines and many different aspects of service delivery. Of course, ultimately, this work involves the application of clinical findings, but there is a lot of community public health and social science involved in making sure that clinical findings reach the people in the communities that need the help most. One of our new efforts to scale research capacity building is through an alliance with the Indian Institute of Public Health, Hyderabad. And this was back in the good old days when we could actually have a face-to-face meeting. We brought together research teams from several countries to Nepal to investigate how to go about establishing a community of practice around research capacity building. Based on that meeting, which was facilitated by faculty from the Indian Institute of Public Health, Hyderabad, we designed a program. It became a 20-month program. We will complete it in about 7 months. We have hospital teams. We don't just involve one person. Remember that article from Arbo. We involve the medical director of the hospital, the research head, and practitioners in the topic area of the research being designed by that institution. We, with the Indian Institute of Public Health, hold large group learning sessions and also small group between classroom work. There's intensive coaching, and a lot of input goes into these research teams. You can read this outline and it'll look like your outline for absolutely any research design course you've ever taken. We put a lot of time into developing the question. Very few of our partners have ever had the liberty to step back and look at all they're doing and say, boy, I really wish we could know something more about this or this. And it starts a conversation that's very creative, very engaged, and it results in a team defining an important topic. Then the study protocol development. We all know what fun that is. The research design, the sample design, the looking at the questionnaire, all these issues are addressed by these non-researcher teams who are getting this experience under their belt through this research and through helping each other. The ultimate goal is to develop findings that are very useful for that program and for others, and share the findings and apply them internally to the institution and globally. We all have to have our Zoom photo somewhere. Our workshop, of course, was going to have involved 3 face-to-face sessions punctuated with online coaching. It turned out it all became Zoom through the COVID, although we do hope to have a celebration in person, which is the kickoff to phase 2 of this project with these original research teams and the others we'll be adding. Speaking of research teams, one of the teams who came to that last face-to-face meeting we had in Nepal in December 2019 were from the SEVA Cambodia staff. We were very fortunate to have them take part in the research workshop, and they have used their participation in the workshop to frame and complete a number of projects of great importance to them as people who are getting services to the field. I'm just giving a brief example of 2 of the studies conducted with and by the SEVA Cambodia teams, the local partners, and with coaching from SEVA Foundation, SEVA Canada, and International Institute of Public Health, Hyderabad. I just want to give you a sense of how basic, how practical are the questions that people are asking. For example, does it make a difference if you put the time and effort into enrolling and creating awareness among village leaders? Well, it really does pay off. And we wanted to demonstrate more about how and why, and you'll get to read the article. Beyond that, we also want to know, okay, for a community outreach program, now that we put all this effort into services, we've got quality services, people are not coming in the volume they could be managed. We then experiment with different approaches to conducting community outreach. And again, this is a way that we can help determine how to reach more people affordably and sustainably. So essentially, as we look ahead, I see that the future is bright for capacity building work in research. It's going to take these steps, however. We have to continue to build alliances, and meetings like this are very critical for this. We also need to identify funding for collaborative research and skill building. Much more is needed than is currently available. We also need to be sure who is getting trained. Yes, we do need to have the MD ophthalmologist, PhD, well-versed. We also need to have people closer to the ground who are doing the work, who at least bring skills of analysis that they can use for designing their own services and for reviewing the literature, which very few practitioners learn how to do. And finally, our goal is to apply the research findings to improve eye care locally as well as globally. So thank you very much.
Thank you, Dr. Gilbert. So the next presentation will be, thank you, Dr. Gilbert.
Thank you.
Thank you. So the next presentation will be Vision and Happy Aging Asian, Identification and Improving Quality of Life Among Older Adults in Chronic Irreversible Ocular Diseases. This will be presented by Dr. Lisa. Dr. Lisa, please.
I'm Professor Lisa Shamini from Malaysia, University of Science Malaysia. I'm a clinician scientist. I've been trained as ophthalmologist, and this is my PhD. Can you hear me?
Yes.
Yes. Yes.
Okay. Hold on. I have a problem of moving my slide. Let me stop to share for a while and share it back again. I'm still having a problem of moving my slide to the next slide. I stopped share for a while again and try to get it. Then. Hold on. Oh, I still cannot do it. Let me just go through, not to have a slideshow then. Okay, this is my presentation on Vision and Happy Aging ASEAN of ASEAN. This is actually a proposal for future collaboration with all the ASEAN countries. Okay, this is my disclosure. And as you know that more and more people in the world are aging rapidly. In fact, it's projected by WHO in 2050 that more than 1 in 5 people will be more than 60-year-old or older. And as we know, the one that really rapidly expanding economically and also exponentially increasing the aging population are in Asia and ASEAN countries. For example, you can see here in Thailand, it's being estimated in 2030, there will be 26.9% of the population will be in the aging population, which is more than 60. While this happens, what's going to happen is more and more households will have aged elderly in their household. It's estimated in 2030, there will be 1 in 2 each household will be having an aging population. Right, but while the aging population, of course, will have their physiological aging, at the same time, at that particular age, they will have concomitant systemic comorbidities such as diabetic hypertension, but at the same time, it's the chronic eye disease, which is mostly age-related, like glaucoma, age-related macular degeneration will comes in. And of course, all these three factors entwine together and actually will affect the quality of life. And we know that the quality of life in older adults are complex because they are integrated with the religious, with the social cultures, the physiological status, the economical, financial status of the family. And at the same time, if the quality of life is not good or not being taken care of, the disease process of glaucoma, age-related macular degeneration tend to progress faster. So hopefully by giving the attention to the quality of life, they will reduce this in progression. Sorry, I have to stop sharing again. Okay, based on the report by this ERIA, the ASEAN countries are not really prepared for this increase of aging population. Most of the ASEAN countries are depending on extended family to take care of the aging, but at the same time, due to the expansion of the economic growth, most of the young ones are in the city compared to the older ones the rural or suburban area. At the same time, the facilities and workforce is inadequate to help them out. And of course, there is none of the report of how they were going to help in terms of the visual impairment among the older age group. We hope with the collaboration with the National Eye Institute, we can kind of be able to actually move forward to have something like Salisbury Eye Evaluation Module in one of the ASEAN countries. I have conducted a research recently for the past 5 years, whereby I call this Malay glaucoma eye study. The reason I'm focusing on Malay because as you know, ASEAN are very diverse population with many ethnicity, and you know the research on the ophthalmology research particularly have been done a lot on Chinese and India, but very minimal research was done in Malay. The only one that we can find perhaps is Singapore Malay eye study. And as we know, Malays contributed 5% of the world population, and mainly most of them reside in Malaysia, Indonesia, part of Thailand, Singapore, Brunei, and also Philippines. So it's very important for us to understand how this glaucoma affected the Malay population in ASEAN. So now I am in the phase 2, whereby I call this MAGIS 2. I completed MAGIS 1 recently, whereby in this study I recruited around 500 primary open angle and primary angle closure and 500 controls, so 1,000 that we have passed on the questionnaire on smoking, physical activities, diet, and also quality of life. We also did a genetic study and we looked into the severity and progression of the disease based on questionnaire and also the labs results. What we have found is there is a lot of our patients who have poor quality of life. Some are depressed, some are anxious, some are not fully, their diet are not so good. So we proceed to MAGIS 2, whereby based on what we have in MAGIS 1, we are trying to build up or create or develop a module, rehabilitation module, to increase their mobility, navigation, exercise, reading ability, and to look back into quality of life after this intervention. So based on our finding, I'm so sorry because I can't really do a slideshow, so it was overlapping. Basically, the MAGIS 1 is a cross-sectional study which involves many hospitals in 4 states of Malaysia, basically Kelantan, Terengganu, Kedah, and also Selangor. And we use all these questionnaires and look into the aspect of their life, how they affect their life in terms of daily activity, emotionally, and also the progression and severity of the disease. these are among the publications that we have produced based on the first steps of our studies. We have a secret smoking, physical activity, and also quality of life. Okay, what I'm going to propose for our collaboration, basically what I call ASEAN, is basically the objectives are to understand the impact of this glaucoma and AMD on the daily activities of these patients among the Asian countries, and also we have compared it with those with developed countries. We identify the factors that affect the quality of life among them, and we try to adopt or use the rehabilitation module that will be created later on in all the Asian countries that's involved. And these are the suggested collaboration whereby we can do a study in phase 1, phase 2, and phase 3. We can start by selecting the appropriate questionnaire for both glaucoma and ARMD and translate and validate that into the national language so that it will be easier for the patient to answer. Then maybe we can do the recruitment in we sample that based on rural, suburban, and urban area. And we try to look into their socio-economic status. And perhaps phase 3, we can do a randomized control trial by, intervene with the rehabilitation program. And perhaps if these materialize, we can have principal investigator from each ASEAN country, and we need a huge team which comprised of occupational rehabilitation specialists, optometrists, and gerontology. With that, hopefully whatever we're going to plan in the future, we will be in tandem with what is expected by WHO Decade of Healthy Aging. Thank you very much.
Thank you, Dr. Lisa, from the information from Malaysia. So the next presentation will be developing and sustainable diabetic retinopathy screening program in Indonesia, role of collaborations. Will be presented by Dr. Yeni from Indonesia. Dr. Yeni, please.
Thank you, Dr. Ngamke. Good morning to all colleagues in Asia, and also good evening to all colleagues in the United States. Let me share my screen. Okay. Is it seen already? Can you see my screen?
Yes. Yes.
Yes. Okay.
Yes.
Please allow me to introduce myself. I'm a community ophthalmologist at a tertiary referral center in Jakarta, Cipto Mangunkusumo Hospital. I'm also a lecturer in Ophthalmology Department, Faculty of Medicine, Universitas Indonesia, and also a community ophthalmology interest group as a head of the group, and also a international representative officer at Indonesian Ophthalmologists Association. I have a bachelor and also a specialty education from Faculty of Medicine, University of Indonesia, and also a master in public health for the eye care in London School of Hygiene and Tropical Medicine in UK. And today I would like to share our project the goal is developing a sustainable diabetic retinopathy screening program in Indonesia, and we will talk about the role of collaboration. As we know that in global, the number of patients with diabetes, people with diabetes is it will increase 51% in 2045, and in South Asia alone, the number it's even bigger. Yeah. The increasing is even bigger, reached to 74%. And in Indonesia, the burden of the disease is huge. From the data, from the research data by Yao in 2012, NEDR will occur in 35% of people with diabetes, so it's 1/3 patients. And if we extrapolating this prevalence to the Indonesian population, we will have like 3.8 million people with NEDR, and also 0.4 million patients with VTDR and 0.2 patient with DMA, diabetic macular edema, and also 0.2 million patient with proliferative diabetic retinopathy. And one of our colleagues already published about the diabetic retinopathy healthcare costs in Indonesia, and they're estimated that there will be an increasing in 4 times of the healthcare costs from 2070 to 2020. And if we look in details, the cost for the healthcare cost for advanced level of diabetic retinopathy is 1.5 more expensive than if we do some prevention or to blindness, and we do the screening program for diabetic retinopathy in community. This slide is represent or suggested by Dr. Tin that we should have a paradigm shift on DR prevention of blindness program in our community, that we should move the focus of the therapy or the management from tertiary prevention into the primary and secondary prevention, as the primary and secondary prevention have a broader population, so it will get more impact and more cost effective. And there are very novel technology for DR prevention blindness program. Yeah, the networking, the use of smartphone apps, digital big data, even the use of telemedicine based on DR screening program with the artificial intelligence is become a trend now. So this program cannot be tackled by ophthalmologists alone, and the collaboration is a must. So we conducted a diabetic retinopathy screening project, collaboration between the IOA and Novartis, and we plan to do the screening for 10,000 people with diabetes in 3 provinces: Jakarta, Yogyakarta, and West Java. And the target group will be adult with diabetes in Jakarta, Yogyakarta, and Jawa Barat. And the objective of this project is to improve access and long-term compliance with diabetic retinopathy care, and increase awareness and knowledge of DR among people with diabetes and also the health provider, raise the awareness and providing database of diabetic mellitus patient for developing a model for systematic DR screening program in Indonesia. And furthermore, this data or this database, this result of the project will be used for advocacy in policy changing for DR care in Indonesia. And including in this program or project, there are several studies covering the prevalence of DR and other eye condition, the risk factor and comorbidities, the quality of life of diabetic patients and diabetic retinopathy patients, the KAP study, cost analysis of healthcare of DR services, the use of artificial intelligence in diabetic retinopathy screening, the awareness, and also the barriers in uptaking of DR services. And this is the model we propose for the screening of diabetic retinopathy at the primary level healthcare. So we're going to use the mobile fundus camera because we know that until now, no primary health facility already have the fundus camera. So we are going to use the mobile fundus camera with the team, and the data will send to the data center, and especially in Jakarta, we are conducting a research to do the validation study of AI software, which is we are collaborating with Delft Imaging using the RedCat software, and the patient that already screened and have a DR will be referred to the secondary level of care, and if they need further treatment, the patient will refer to the tertiary center to do necessary further treatment. The referral pathway, the referral system is already there, and we are trying to integrate our program into the available or current health system in our place. And this is our target. We are doing an awareness program for 300,000 people, and we will be screened 10,000 people with diabetes, and we're predicting that there will be 60% of DR and other eye condition, and of the 60%, there will be 50% patient will be referred. And we identified the key components. We are going to creating the main demands by using the awareness program. We have to have a good administration. We do the screening test, and we prepare the reading center, and also we prepare also the grading process, include the use of artificial intelligence, referral system, and also the quality assurance. And the most important ones that our result can be used for policy changing in order to give a better services for diabetes patient. And these are our partners in doing this program. And for conclusion, DR in Indonesia is emerging disease. Therefore, screening in Indonesian population should be implemented. And we know that our project is only a baby step for developing a model for systematic DR screening program in Indonesia. And collaboration of all stakeholders is a must. Thank you for your time. Thank you.
Thank you, Dr. Jenny. And the next presentation will be presented by Dr. He from Vietnam. But Dr. He cannot join this meeting, so we'll skip this presentation and move to the next presentation that will be experience with the Fulbright program, and will be presented by Dr. Helena from Luna. Dr. Helena, please. Okay, so we are going to the next presentation. The potential for scientific collaboration in Southeast Asia. This will be presented by Dr. Paisan Rovibonsu, and he is the one who worked very hard for this meeting. Dr. Paisan, please.
Dr. Ngam Khair.
We move to the next presentation of Dr. Paisan.
Well, we can do that. Actually, I'm supposed to be the last, and then I'll send over to the Director General of Department of Medical Services to close the session. But it's okay. I can give a talk here, and then if Helena is ready, we can switch to her talk, and then I can come back to introduce the Director General again. Here's my bio. Well, I'm currently the Secretary General of the ASEAN Ophthalmology Society. Well, my talk's supposed to be the last talk, which is a kind of wrap-up of this symposium. Association of Southeast Asian Nations was founded by 5 countries at the beginning in 1967, Thailand, Indonesia, the Philippines, Malaysia, and Singapore. The objectives were to improve economic and political stability and social progress among the member countries. Well, we are expanding into like 10 countries at the moment. In 2019, the total population of all the 10 ASEAN countries amount to be estimated of over 650 million inhabitants, about roughly 8.5% of the world population. Well, ASEAN is currently the third largest economy in Indo-Pacific region and the fifth largest in the world. Well, here you can see the comparison between the GDP of ASEAN and China and Japan. We just follow China and Japan with totally $2.8 trillion as the world GDP as a whole. If you have a look at the real GDP growth from 2008 to 2017, the growth of ASEAN nations' GDP is around 50%, behind only China and India. Well, in fact, if you have a look in each individual country, in terms of GDP per capita, you're going to see that, well, we have Singapore, our richest country, which has GDP per capita on par of the US. But we have like 5 other countries in ASEAN which can label into the low-income countries. There's a whole gap there. And there's a whole gap in terms of ASEAN education as well. You can see, well, we have 2 top universities in Singapore, which is ranked within the top 20 university of the world. And we have totally 18 universities in ASEAN, which is ranked in top 500 universities in the world. But those universities are from only 5 countries. Well, this is bad news because the largest number of people with blindness and moderate to severe vision impairment reside in South Asia and also Southeast Asia. And you can see the causes of blindness. Well, 9 out of 10 ASEAN countries still have cataract as the leading cause of blindness. You see the number of cataract surgical rate, which is CSR label over there, I mean in the table. We have the most number of CSR in Singapore, which is almost 7,000 CSR. But you can see Laos have only like, well, less than 800 cataract surgical rate. There's a wide gap there for get rid of blindness from cataract. And if you can see the number of ASEAN ophthalmologists, we have the countries with the highest number of ophthalmologists in ASEAN: Brunei, Malaysia, and Singapore. They have a ratio of like 1 ophthalmologist out of 20,000 people, or 1 ophthalmologist out of 30,000 people. But we also have countries like Laos and Cambodia, which have ophthalmologists 1 out of 200 or 300,000 people. So there's a gap there for ophthalmic care. For example, for cataract, we have some challenges in improving cataract surgical rate, especially in countries like Indonesia and the Philippines, because we have a kind of like a limitation for geography, because the 2 countries contain like thousands of islands. We have countries with low number of ophthalmologists such as Laos and Cambodia. And also even in Thailand, we still struggle to screen blinding cataract. We still need a nationwide screening program for blinding cataract, and we use the village health volunteers of doing that. There are some challenges in accessing anti-VEGF treatment for retinal disease in some countries as well. And luckily, well, many countries follow the footsteps of Thailand to try to put bevacizumab into the national list of essential medication to allow all the people in the country to get access to anti-VEGF treatment. In terms of residency training, here the list are those societies responsible for residency training in ASEAN countries. You see the number of residency training are quite vary among countries. And well, in terms of quality, there's still a wide gap there as well in terms of quality. But I think we can bridge the gaps for ophthalmic education. We can learn together. We can establish the kind of exchange programs for course or short course, residency or fellowship training among our ASEAN member societies. We can learn from other countries as well. There's a kind of inbound training. We have like visiting mentors from around the world come to Laos, Cambodia, Myanmar. I believe KCI has some training for Myanmar and some NGO as well. We have outbound training. We have a lot of ophthalmologists in ASEAN travel abroad for getting fellowship training. And you can learn from us. The world can learn from us as well. Singapore National Eye Center, SNEC, accepts fellowship in various subspecialties from various countries. And we are quite open for worldwide eye residents and fellows to gain international experience. They can have an elective course here in ASEAN countries. In terms of eye research publications, this is a look back in 10 years. You can see that, well, the number of publications from Singapore is almost 2,000 within 10 years. Well, if you sum up all the publication from the rest of the 9 countries together, they are even less than Singapore alone, only 1 country. So we have a wide gap there as well in terms of research. I think in terms of research, well, I think we need the current reliable data of eye disease. For ASEAN, we can view ASEAN as a single population, but we don't have the data for ASEAN as a single population. The data is kind of fragmented. We need to specify specific research questions to address ASEAN problems, just like Tien said in his remarks. And we also need to build research infrastructure for ASEAN. And this is important, as Tien said as well, we need to have the new blood, the new young generation of eye research for ASEAN. We have strength in ASEAN. Singapore Eye Research Institute, SIRI, is one of the world leaders in eye research. And we are quite open for international collaboration. And I think this symposium is an example of how open we are. We are open to collaborate with U.S. National Eye Institute to have some kind of collaboration research in the future. We are very open. And well, may I take you back in time a little bit to the year 2013? Well, in May 18, 2013 in Bangkok, that was the first time that we have a summit of ophthalmological society from ASEAN countries to get together. And I think this is the historical picture. This was the first time that the 10 countries, the 10 societies get together, and we was holding hands and make a commitment of establishing a new society together, which is ASEAN Ophthalmology Society. And here's the signatures from the 10 society, the 10 countries, from the MOU from that day. And then we have the first Congress of the ASEAN Ophthalmology Society in Bangkok in 2014. And then here in this meeting today, well, I think today is a great opportunity for ASEAN countries, ASEAN Ophthalmology Society, to bridge all the gaps and then fill the gaps in ophthalmic care, education, and research, which are the challenges for ASEAN Ophthalmology Society. I'd like to end my presentation here, but if Dr. Helena's presentation is okay, it's ready to go at the moment. Dr. Helena's presentation. Not yet? It's okay. So, well, may I take opportunity to thank especially the organizing committee, Dr. John Prakash from National Eye Institute, Dr. Mitch Briggs from KCI Institute, Portland, Oregon, Paul Chan from Chicago, USA, AO. But we work together very hard. Well, we have chats many times via telecommunications to organize this. And Dr. Ruben Rim, the president of AOS, who support this meeting. And I would like to thank all the speakers and also the audience who stay with us until this very moment. Well, the host of this meeting is the Department of Medical Services, the Ministry of Public Health of Thailand, and the co-host is the U.S. Embassy in Thailand. And here you can see on the screen at the top row are all the sponsors of this important event. And of course, National Institute of Health, National Eye Institute is also the co-host of this event. The other sponsors include American Academy of Ophthalmology, of course the AOS, the KCI Institute, the IAPB, Illinois Eye Institute, Rajashri Hospital, Siva Foundation, Singapore National Eye Center, and Department of Ophthalmology, Thailand Hospital. Thank you very much for your support. Thank you very much for your kind attention until this point. Thank you. Is Dr. Helena's presentation ready? So can we? So well, if it's unfortunate that Dr. Helena's presentation is not ready. So, but I think we have to move on. Sorry for that, Helena. Maybe next time we'll get together again in the future. So I think it's time to wrap up this meeting. I'd like to thank again for the speakers and the audience for staying with us until this moment. So the last but not least will be the closing remarks by the real host of this meeting, which is the Director General of Department of Medical Services, the Ministry of Public Health. May I welcome all of you to Dr. Somsak Akasin, the Director General of Department of Medical Services. Can you please, Dr. Somsak, please.
Thank you, Dr. Paisan, for the wrap-up. Good morning from Thailand, and thank you all for being here with us today. And sorry for the high technology problem that some of you cannot present today. We still have, the near future to talk with each other together. I'm glad to know that hundreds of researchers and eye care specialists from different countries in joining this discussion. So please allow me to congratulate the organizing committee and all participants for the successful organization of this event. My grateful thanks go to the United States National Eye Institute and Association of Southeast Asian Ophthalmology Society for your support and making this webinar a success. And as I told you that, sorry for the high technology problem, we have to meet in this kind of webinar because of COVID outbreak around the world. And I personally think that COVID teaches us a lot. It teaches us that, try to do the best thing for medical service may be not enough for the social or society, our world society. So we have to not only doing the best thing for medical services, but think about the socio-economic situation. I think all of you know best in a kind of world eye care service. I might be the one who know least about eye care services. However, I would like to maybe exchange some opinion with you that regarding my department vision, we are now doing both for medical services and also doing the research, as all of you discussed during these maybe 3-4 hours together. For the medical services, we have to serve the most of the population. But for research is how we can try to change or translate the service to be the best thing for our population. So we have to be both, both serving the most and doing the best. In Department of Medical Services, my department, we try to use the term how to bring the best for the most, in case this for the most of the Thai population. And again, congratulate that you have discussed many good things for trying to do research to be the best and bringing this for the most of the of our population. And another thing that we try to do in our country, and I do believe, I personally believe that maybe most of you try to do the same thing, that we try to change the medical services from hospital-based to be the personal-based medical services. Let me share one experience. for eye care, services with you. Dr. Paisan, one of the organizing committee, has done a research for the AI for eye care with Google. That I think is the thing that very good. Try to bring the best for the most of the population by try to bring the kind of hospital-based medical services to be a personal-based medical services. In my department, I think we think that the two key issue thing is how we can redesign the medical service. In case of Dr. Paisan, he used the digital disruption, doing research with Google. So this is the two things that we try to do: redesign the medical process, and then use the digital disruption to bring the best thing from the research for the most, that means for the services. That is my personal view and also my department view that we try to do. So again, I think you have done a lot for eye care, both services and research already. So this is my talk that I would like to exchange with all of you. In fact, Dr. Paisan has wrote a lot beautiful things that he would like to share, but I would like to share my personal view to all of you. And before I end my closing statement, I'm pleased to inform you that Department of Medical Services, my department, and also Ministry of Public Health of Thailand, we stand by ready to work alongside with you to move our collaboration forward and ultimately to reduce vision health risk factors for the wellness of our world population, both in US, in ASEAN, and also in other countries around the world. I wish you all safe and have a wonderful day and days ahead, and stay safe from COVID. We are looking forward to welcome you all to Thailand once if this COVID outbreak has come to an end. Now the vaccine has become more available, and I personally believe that we can end the COVID crisis within maybe the third or fourth trimester of this year. Have a good night to all colleagues in the US and to my ASEAN friends and other countries around the world. Enjoy your rest of the day. Thank you and ขอบคุณครับ สวัสดีครับ